Dr. Ramesh hasn't got his badge.
You are live, ma'am.
Okay. A very good evening to one and all of you to this ARC webinar on enhancing concepts in cataract surgery. Today we have an abundance of equipments, but we need to have clarity on how best to use each of it to its ultimate advantage. I wish to warmly welcome our great expert panel and the very ideal set of speakers we have amidst us to throw light on the specific topics. We have with us our expert panel, Dr. Mahipal Sachdev, who would be joining anytime now, who's the chairman and MD of the Center for Sight Group of Hospitals, our immediate past president, who brought in very robust changes in the functioning of AIOS, raising its bar. We have with us joining anytime now, Dr. Ramurthy, our past president and chairman of the Eye Foundation Group of Hospitals, with a great insight into technology reigning in ophthalmology, and he is definitely going to give his inputs in this webinar. We have with us Dr. Namrata Sharma, Honorary Secretary of AIOS, a driven personality who has been bringing in visible changes in AIOS. We have with us, thanks a lot, Dr. Rohit Shetty, for joining us, Vice Chairman of the Narayan Netralia Group of Hospitals at Bangalore, a true visionary, a great researcher who has raised the bars for all the innovative thinkers of our country to outbeat themselves. We have amidst us Dr. Nitin Balakrishnan, who is the Medical Director and Head of the Cataract and Refractive Surgical Services of Sai Deep Eye Clinic and Crystal Vision Laser Center from Mumbai, with an exclusive best practice patterns to add energy to our webinar. I'm lucky to have co-moderating with me two of my big strengths of ARC, Dr. Anaga Harur, who is the member ARC West and medical director of Anil Eye Hospital and a very prolific surgeon and immense extracurricular capabilities also. We have with us Dr. Satyajit Sinha, I'm sure a very popular figure over the years in AIOS, who's member ARC East the second time round and also the chairman and managing director of ABI Hospitals Patna, another great hero in his region. So, and of course, we have this time another moderator with us, Dr. Srinivas Joshi, who's member ARC South, who's actually a dynamic figure amongst the youngsters and amongst the seniors, a surgeon par excellence, whom we all need to learn from. So this time I'm actually lucky to have one moderator being absent, so three of them have chipped in. So it's going to be a really exhilarating webinar. So I would be the first speaker in this session.
I'll take this opportunity to invite our first speaker, Dr. Chitra Ramamurthy. As we all know, she is one of the most dynamic ARC Academic and Research Committee Chairman of All India Ophthalmic Society at present, and she is doing some amazing webinars and amazing work as ARC Chairman, which was never seen earlier. Very warm welcome to you, Dr. Chitra Ramamurthy. And she is also the director of the Eye Foundation, chairman of Eye Foundation in Coimbatore. She will be talking on update on IUL power calculation. Dr. Chitra Ramamurthy, please.
Can you see my screen now?
Yes, ma'am.
So let's start off with the first routine talk before we go on to more challenging ones. So essentially, why we need to have a greater insight into IOL power calculations is because of the increasing expertise of the surgeons, yes, but also because of the increasing desire of our patients to get target immertropic outcomes. It's not going to the next, yeah. So if we try to trace the history, it goes right back to the times of Harold Ridley, who discovered the first intraocular lens in 1940s, and in his lifetime in 1980 underwent a further modification of this lens during his cataract surgery. But today, where we stand, we are able to realize a target immertropic outcome within plus minus 0.5 diopter for most of our normal patients may be challenged in extremes of axial length and post-refractive surgery. So it automatically tells us that we need to do a very careful biometry and choose the right formulae. If you try to understand what are the existing biometers which are popular now, yes, we still do have immersion A-scan and the different optical biometers today, but there is some difference which is there, which is not very overpowering, of course. Like if you look at the ultrasound, it works at the frequency of 10 megahertz as against an IOL master, which works the frequency of 780 nanometers. In other words, definitely it goes without saying that there is a greater penetrance and greater accuracy and that fixation check, which just makes it even more accurate. But having said that, the ultrasound also does detect in a good range, maybe a little variable between the two would be about 200 nanometers. If you look at the immersion biometry, what is most important for us to see is that the spikes of the cornea, the anterior and the posterior lens, the retina and sclera should be of nearly equal amplitude, and the standard deviations amongst these a few readings should not be more than 0.06. We should not compress the eye, and we should keep our gain lowest at which you get these amplitudes. As far as the optical biometers are concerned, we have different ones at slightly varying principles, but all getting the most optimal end result. If we talk of the latest of ones is the IOL Master 700, which has incorporated the swept source OCT, combined it with the B-scan biometry, wherein it measures also the corneal thickness and the lens thickness, and again has that phenomenal fixation check and the 3-zone telecentric catarametry. So what are the sources of error? The one major error is our difficulty in estimating the effective lens position, and commensurately the post-op refraction gets challenged and the axial length measure. This constitutes about 79% of the error, and the corneal contribution is about 21% because we need to have not just a comprehensive measurement in normal corneas, but we need to get the final answer in abnormal corneas and corneas that are modified surgically. We, of course, have a conglomerate of technologies, but they all measure at different points, like manual K at 3.2 millimeter ring. The IOL Master has 3 rings with 18 spots, and the Lens Star has 2 double rings. So essentially, even manual keratometry is fairly okay because it also gives us a measure of the magnitude of astigmatism and axis. But what is this new thing about the total keratometry which is being talked about? Essentially, what it does is it uses a toric model and measures on the anterior corneal surface, and with the help of the swept source OCT, measures the corneal thickness and interpolates the posterior corneal thickness values and gives an estimate of the total keratometry. Now, this can be incorporated in the Barrett's Universal 2 and gets called as Barrett TK Universal, in Barrett Toric, and gets called as Barrett TK Toric, and more. But then, if this total keratometry gets incorporated in the other formulas, we need to remember that the other formulas have also derived some kind of a mathematical calculation to estimate the posterior corneal astigmatism. And we should beware that if we do this, we might end up overcorrecting it. And what is this? I talked about telecentric keratometry. It is the ability to maintain your constant spot distance, irrespective of whether the chin is on the exact position or the headrest in the exact headrest. In other words, it's a distant independent keratometry. So the preoperative workup is critical. So we've understood that the biometry is critical, but also the need to stabilize the ocular surface is so important. Now, if you look at this example, the left eye is showing an astigmatism of 2.67, where the right is showing 0.5. And we looked more deeply, we found that the patient had severe dry eyes, and following medications, the astigmatism dropped to 0.2 in both eyes. So that tells us how important it is to have the right measure. Now, this was again another patient who came for a cataract surgery, but you need to do a closer look, and we found that the K values in the right eye was flatter compared to that of the left eye. And then the patient comes out with a history that they had done LASIK 30 years back. So then you need to immediately change the mode and the formulae for laser vision correction in the right eye. So these become important. It also becomes important to verify the quality of raw data, like if the astigmatism is more in one eye, is it some abnormal topography you're looking, is the axial length measure more, or is it invariance or asymmetric in both eyes? We also need to understand there has been a generation gap in our understanding the IOL formulae. Like earlier, we started off with the theoretical formulae, and then came the versions. And today we have the Gaussian formula, and we have further gone on to more statistical ways of understanding. Like with the versions, the advantage was that we started incorporating 2 variables, 3 variables, and 7 variables in measurements in the very process of trying to get more precise on the effective lens position, which was the major challenge in the understanding or the evolving a better accurate IOL formula. Then came the artificial intelligence Hill RBF, which is essentially a very robust statistical model, which kept evolving so that the predictive error became even less in it. And of course, the ray tracing. So the next valid question is, how are the newer formulas different from each other? The essence is that each of them are trying to get best in measuring the effective lens position, because if the lens is little anteriorly placed, it needs a lower power. And if the lens sits a little posterior placed in the capsular bag, it needs a higher power. In other words, it is such a major challenge, and we have to be continuously running after improving our ability to measure this position of the intraocular lens in the capsular bag to get that final target emmetropia. So then, is it bad to use older formulas? No, it isn't. We do, but experience understands the value of these formulas in normal eyes. But let's even look at the Warren Hill database. Like earlier, when they had lesser data, there was 78% of them within plus minus 0.5. But today, with more and more post-operative results being incorporated in the database, there are more than 90% who are within 0.5, plus minus 0.5 achievable target. We even did a study comparing the 3rd generation formula against a 4th generation Barrett's, and you can clearly see that in long eyes, normal eyes, and short eyes, Barrett comes with a greater accuracy over 90% in within plus minus 0.5 diopters. So then, does it mean that we keep plugging our numbers into multiple formulae and compare the results? No, that's optional. Maybe you could try it once to understand with a number of eyes which formula is best suited for an eye. But would we ever have one formula that works for all? No, it doesn't. Because if you look at the dimension matrix of the human eye, what you see is that normal anterior chamber depth and normal axial length is seen in 73.4% of the eyes, whereas a normal ACD with a shorter axial length is seen in 6.9, smaller ACD with smaller axial length is seen in 1.8%, and a normal anterior chamber depth with a longer axial length is seen in 35.5%. So in other words, we need to evolve newer formulas, especially when you're dealing with extremes of axial length. The further advantage of Barrett Universal 2 is it is able to account for the principal plane in different geometry of lenses, like a minus lens or a plus lens, besides the fact that it has all these variables which is getting incorporated, which gives you a greater and a better estimation of the effective lens position. Taking you further on, now, as I said, all that I have said, like this is where you incorporate the name, the A constant, and the personalized constant, and all these essential measurements, and the lens thickness and the white to white become the optional measurements. If you look at the Hill RPF, what we realize is they have optimized now to an extended beta version, which gives precision even up to -5 diopters.
Ma'am,
So
you
what
have
is
1
the
minute
best
remaining.
way to deal with short eyes? Like in short eyes, you know that there could be a normal anterior chamber depth or a shallow anterior chamber depth. And because these are high-powered IOLs, you could have a larger refractive surprise. So you could use a customized IOL or a piggyback IOL in these eyes to add up to the lens placed in the bag. And in the challenge with the long eyes is the presence of cephaloma, which are better measured with the optical biometers. With the post-refractive surgery eyes, we have different solutions. Essentially, it is because the ratio between the anterior and the posterior cornea is altered. So we have the total keratometry, we have the pentacam EKR or the Galilees. So, but then you could use either the ASCRS calculator, which would give you the pre-op data and the post-op, no prior data, and then helps you allow you to measure. You could use the OCT formulas, which have come forward. You could use the myopic classic formula, wherein you need to use the least minus with which, because keeping in mind that we tend to underestimate the key and we could overestimate the IOL part. Now, this would be vice versa in the hyperopic eye. And these are the different formulas which could be used, and Barrett Truque definitely stands strong as far as this is concerned. And you could even get access to this in the apsrs.com or the ASCRS website. Radial keratotomy again has its own challenges and the difficulty in estimating ELP. So the challenge is how close to the center of the cornea can you get? And today with the ARCRS calculator, we do have the post-RK values to be measured too. Essentially with RK, of course, we need to be cognizant that there's going to be a challenge in the stability of the refraction in the first 2-3 months because of the transient hyperopia, which is there. Again, toric calculators have the Alcon calculator, which has the Barrett's algorithm incorporated. It has also the Barrett toric calculator, which can be accessed online. Even if you have the immersion biometer values, you could just add on the acoustic constant of the IOL power, which you're going to use, and it would give you the access and magnitude. Essentially, whether you use the immersion or the optical biometers, you could still avail the newer formulas and get the best. So what is most necessary is that we keep on validating our measurements. That is, we as a surgeon, we don't remove ourselves from the process, but be along with our optometrists to know what is best we could offer for these patients. And most importantly, we need to stay informed because there is continuous process of evolution and latest developments are occurring, and we need to continuously improve ourselves and get best out of our own selves. Thank you very much. So what I would do is, I think I need to stop sharing my screen.
Thank you, ma'am.
Have I stopped sharing my screen?
Yes, ma'am.
You have stopped it.
Yeah.
Yes, ma'am.
Yeah. Before we go on to discussing this talk, I thought we would go on Dr. Ramesh's talk.
Question for you.
I wondered, Anaga.
Yes, ma'am. I wanted to ask a question.
No, can we do something? Can we take Dr.
Voice is
Ramesh?
not coming clearly. It's
And
echoing.
now it's better. Now it's better.
Anaga, I
Yes.
felt that we could take Ramesh's talk and then combine
Fine.
IOL part calculations questions in that.
Sure,
Okay.
ma'am. Yeah.
So our next speaker is Dr. Ramesh Rajan, heading the Sundar Eye Hospital, Chennai. And we are all aware that he does a great quality work and has been doing so with over 33 years of experience. And he is the right person to deal with this very difficult topic. On to you, Dr. Ramesh.
Can you see my screen?
Yeah.
It is seen? Okay, thank you. So my talk has two parts. That is biometry in atypical eyes.
Sir, can you go to the slide mode?
I started screen sharing. Can you see them? Or
Yes, sir, we can see it. If you can just put a slideshow mode, sir.
Oh, yeah, sure. Is this better?
Yeah.
Now it's all right.
Thank you so much. So I have two parts. One is biometry in atypical eyes and some tips to minimize the errors. So the first comment has to be that we have to thank Dr. Warren Hill for having a wonderful site, drhill.com, where all of us, the students and the practitioners, can update our knowledge about biometry. He takes great efforts and it keeps changing every few months. And although we've all seen it several times, it's worth going back there again. So my first tip is to use the immersion and not the contact ultrasound. And the reason for doing this is very simple. You can see in this particular series of examination, the anterior chamber depth is 4.10, 4.05, 4.29 mm, 4.39, 4.00, 4.05. So the ACD varies from one examination to the next when we do a contact method. And this gives us varying axial lengths. We're all aware that the vitreous cavity cannot be compressed, the lens thickness cannot be altered, but variable corneal compression is the reason why we are getting variable axial lengths with contact ultrasound method. So all of us should follow the first tip, which is to move on to immersion scan. So this is a series of measurements taken in one of my patients where you can see here 2.38, 23.48, 23.48, 23.49, 23.48. You can take any number of measurements and they're all grouped together. So the variability that you see with the contact ultrasound is not there if you're doing immersion A scan. Till you convert totally to immersion A scan, if you're doing contact biometry, please do it with the patient lying down. This is a single important tip that I can give you to improve your outcomes for measuring the axial length. The patient should lie down, hold the probe by the wire. The patient should extend the other hand and fix it at the tip of the finger, and that will keep the eye aligned properly. You can also use a wired speculum if you wish after applying paracaine to make sure the patient does not blink. The next tip is you have to calibrate all your instruments once in a while. In my calorimeter, I find I have to calibrate the ocular end, the eyepiece for zero error quite frequently. The next thing is to optimize the corneal surface before keratometry. Please think of doing biometry and topography when you're thinking of doing toric IOLs. Like Dr. Chitra mentioned in her wonderful and extensive talk, use a validation criteria. For example, if you have a difference of more than 3 millimeters in axial length between the two eyes, it's worthwhile checking all the measurements again. Get to know your instruments and your staff for using them and give them the power to come back to you if something is not perfect. And these are some interesting tips for atypical eyes. We all know that for myopic LASIK, we have to use a negative aspheric lens to compensate for the central flattening of those corneas. And in silicone oil filled eyes, it's best to use a PMMA or a hydrophobic lens. The last is a tip which I learned recently from Dr. Arul. For all keratoconus patients, to get excellent uncorrected distance visual acuity, he uses trifocals. And why does he get such good results with trifocals? And the reason is probably because in keratoconus, we get a hyperopic error depending on the K of the cornea. The steeper the cone, the more hyperopic the error tends to be. So it's easy to get a +2 or a +3 error in patients with keratoconus. If you're putting a trifocal lens, let's say of power 18, you're not only putting a lens with power 18, you're also incorporating a 19.5 and a 21. So you get 3 hits at getting emetropia in patients with keratoconus if you put a trifocal. So this is one interesting tip about choosing the intraocular lens. Quality checks are very important. In an autokeratometer like this, you have to look out for those kind of less than perfect dots, which is probably because of mild dryness of the cornea. The newer instruments like Anterion and IOL Master 700 make it very easy for you. They cue you in when something goes wrong, like you have a red dot here saying that you can't take the measurement. And during the measurement, it tends to guide you, it tells you. Okay, so it tends to tell you to move the whole instrument to the right, to go back, to go forward. And here you can see the dry spots which are coming on when my assistant asks the patient to open the eye wide. So after the series of tests are done, it also, before it does the calculation, it forces you to examine each value. This we have to do. We have to examine each value and see whether we have a perfect cornea which was measured, a perfect white to white which was measured, whether we have a macular hole like ARMD posteriorly. So by forcing us to re-examine all the data points, we know that it is not a garbage in, garbage out, but we actually have a good quality values which we are feeding into the eye. In this particular movie, we can see the, if you force your patients to just take the measurements and come back, due to pressure of time, they will try to take a K even in an eye like this. But an eye like this will not give you good results. So you can see that how when the cornea dries, when the corneal surface is not perfect, you can have an extremely disturbed mire. So it's very, very important that you give time to your patients and you give time to your staff, and you cannot be taking these measurements after we have dilated them. We should not be taking measurements after we have put paracaine on these patients' eye. We should try to take them on a virgin eye, and we should take time to optimize the corneal surface before actually taking the measurements. So careful clinical examination to rule out problems like EBND and other surface issues, accurate measurement, validation of each step are all very important part. And the doctor, like Dr. Chitra said, should be involved in this process. We all know this old statement by David Chang that patient happiness depends on getting 20/20 at least in one eye. But this becomes difficult in atypical eyes. So this is a typical eye. It's easy for most of us to get the majority of our patients very close to plano in a typical eye. But in an atypical eye, and to understand what an atypical eye is, we have to go back to the seminal paper by Dr. Jack Holliday and James Gills, where they describe the 9 types of eyes. Dr. Chitra clearly showed us that 93% of our eyes are normal, but the remaining 25 odd types of eyes either have a large or a small anterior segment, either a large or a short posterior segment. So this combination gives us 9 types of eyes, and one single formula like SRK2 or SRKT will not be enough to get a good value for all these eyes. So we need to have a suite, a buffet of formula, and we have to use the appropriate formula for each patient. For example, if you're going to have a patient where you're going to do a lens exchange or a piggyback lens, you should choose the Barrett's RX formula. Right in the center, if you choose to use a toric lens, you must use a toric calculator. And if you have a patient who's had a prior refractive surgery, you have to use that one on top, prior myopic or hyperopic LASIK, PRK, SMILE, or a keratoconus. So these patients have an altered Gulfstrand ratio, which is a dominant factor which gives you an error. And for them, you have to use the Barrett's True-K formula. So you can't have one formula for all the patients. You should choose the formula. Now, Kane formula in the last 2 years there are excellent presentations with large series showing that it is slightly superior to Barrett's. And I think over the next few years, most of us will try out the Kane formula as well as the upgraded Hill RBF formula to see whether our Barrett's is giving the right value or not. So let us come to a few of the atypical eyes. Here is an eye with a small pterygium. It's an atypical eye, but it will be quite easy to take care of this particular patient. Can you tell me how many more minutes I have?
So you have 1 minute.
1 minute, thank you. But if you have a large pterygium like this, which has crossed the midline, my own approach will be to amputate the pterygium, to peel it off, not do a deep scraping and not try to remove all the residue in the central zone, but do a cosmetic clearance only away from the pupil and use the K from the fellow eye for this particular patient. Extreme axial myopia is a challenge, and I will advise all the audience to use an optical biometry or send these patients to a place where an optical biometry is available. If an optical biometry cannot be used due to a density of the cataract, and you have a posterior cephaloma, and a vector AB scan can be done. Vector AB scan is easy when you know where the approximate macula is. You can see the optic nerve here. The macula is probably here. But in an eye like this, where the optic nerve is here, it's difficult to find out where the macula is sited, and a vector AB scan also will give only an approximate value. Pediatric eyes are a challenge, and part of the challenge is trying to get measurements under GA in these patients. Eyes with silicone oil are also atypical. Please send the patient to a center that has an optical biometer. This is the best thing that you can do. We know that sound travels slower in silicone oil, so errors of up to 8 millimeters in axial length are possible. In addition, most of our lenses are biconvex or posterior convex, and what happens is the silicone oil convex surface reduces the effective lens of the effective power of the lens. So we have to add a +2 or a +3 to these lenses to get a better value. We have a rule of 2 when you want to do a lens exchange. If you want to do a lens exchange or a piggyback, please wait for 2 months, and please wait till the refraction is stable on 2 consecutive examinations. Thank you. I think my 10 minutes are up, and I will stop with this.
Thanks a lot, Dr. Ramesh. You did your best to cover a very extensive talk. But Dr. Rohit Shetty is there?
Yes, ma'am.
Yeah, I wanted to ask you, like just now Dr. Ramesh commented about using trifocals and keratoconus. I wanted your thought that the irregular astigmatism and the challenges, could we make a sweeping remark like that for keratoconus?
Thank you, Dr. Ramesh. Always learn the fundamentals in such a beautiful way. And thank you, ma'am, for bringing the entire overview of the formula. The thing about keratoconus, which I want to say is, you have a hit and miss story. Sometimes you do something, you get it right, and sometimes we assume that that's the way to go, and sometimes we do the same thing again on the same different, you don't get it right. So until unless we have a very strong data, I mean, it's an interesting concept about having different lens concept. I think Dr. Arul must have thought about it in depth too before he started using it. But optically, it depends on where your cone is and where your angle kappa is again, because that's where he's trying to see. And if it's a long-standing keratoconus, each one of them try to find the sweet spot in the pupil. Sometimes you have the cone bisecting the cornea. So if you have a larger series, and if you can, if we all can see how the data is, then it'll be very interesting. As an interesting concept, but we have to really see it in larger numbers. That's my take on it.
Probably, I would say that I'd like to add that you would maybe, I don't know, it could be valid in maybe very early cases, but the moderate case itself, you would need to regularize the corneal topography and then go ahead and do it. And in extremes of cases, it sometimes makes sense to place an aspheric AIOS and let the patient wear the
Internet off make na.
I think you all should mute Mr. Admin, because there's a lot of disturbance. Namrata, your thoughts?
I think I would agree with Rohit completely on this, because I feel trifocals for keratoconus would be, I mean, we really don't have too much long-term data, and that too, even if you cross-link those cases, we really don't know what will happen to the abrasions, what will happen to the higher order abrasions that are there, and how they will behave, even if you have cross-linked those corneas. So I think that is something to be seen. But having said this, I'm sure Dr. Durayarajan has experience on it, and probably has a series on it. And if he can, tell us about that, would be good. But I don't think there is enough published literature on use of trifocals in cases of keratoconus.
Dr. Tityal, very warm welcome to you. I wanted to know that how does lamellar keratoplasty alter the corneal curvature, and how that would affect optical biometry, because that is one point could not be covered in our 10 minutes talk.
I think, lamellar keratoplasty for any, corneal pathology is a very good option, especially if you look into post-ectasia patients. This will really give you a new corneal tonicity, and would be a better way to judge these patients. And biometry as such, axial length may not change greatly unless the keratoconus was very, very advanced to begin with. Otherwise, normally it remains same. The only consideration in lamellar keratoplasty also would be the change in astigmatism as the healing process continues, or when you remove the sutures also. So if we have to do some sort of cataract surgery in these patients, it will be better if you remove all the sutures, wait for at least 4 to 6 weeks, if not 2-3 months if possible. Make sure your cornea is totally stable. Then you can have a better biometry for these patients. Only thing, if you have done a manual surgeries or anterior lamellar keratoplasty, then interface comes into play. So that per se might decrease the contrast in these patients. But if you've done a dark, which is a desmetic dark, then it's like a normal cornea. And as far as anterior and posterior corneal curvatures are concerned, there's not much of study to compare normal versus lamellar keratoplasty. But we all know if you've done an anterior lamellar keratoplasty, the posterior corneal curvature change is not much. It is mainly the anterior corneal curvature, unlike in other cases.
But if you have done a DSEC, wouldn't hyperopia get induced because of the posterior corneal curvature? And maybe you need to add, ensure that there is a myopic shift in, induce some myopia in these eyes.
That is true. We normally go for a little bit of change in these cases because you're going to produce a little bit of hypermetropia in these cases.
Yeah.
But with the DBEC type of surgeries, we don't do any manipulation there. But if you're doing an ultra thin DSEC nowadays, we are doing at least people have recommended 1.5 diopter myopia to begin with the early DSEC surgeries. But now we know, as we see these patients, even you have a 150 micron thickness of stroma in DSEC, within a 1 year, the stromal thickness goes down to almost 50%. So that also shifts your hyperopic shift, which is happening. So we don't go for a 1.5 myopia now. Just 0.5 myopia will be sufficient for a new DSEC procedures. DMEC, you don't have to do any change.
Anaga, you had some questions?
Yeah, ma'am, I wanted to ask 2 questions to the expert panel. One is, in case of a silicon-filled eye, if it's a dense, mature cataract where even optical biometry is not possible, what would you do, especially if it's a one-eyed patient? And second is, if it's a patient who has had an RK first and then LASIK also done in the same eye, then, because I had such a patient and that was a one-eyed patient, so I would like to know from the expert panel, what formula would you use and how would you, what IOL would you use? Dr. Himanshu sir, Dr. Tityal sir, Namrata ma'am, Dr. Rohit Shetty sir. And excellent talks first, Chitra ma'am, Ramesh sir.
Yeah, Ramesh could also answer that.
Yes.
Ramesh, your talk was really good.
I'll just take the question on the LASIK plus the RK. I feel you should go with which was a dominant correction. If it was a minor LASIK done for a major RK, you should treat as a post RK eye. Usually these eyes, RK, sorry.
Routine 18 cut RK with LASIK with no history, no papers available, sir.
If were both done on the same
eye.
Same time or at a different time?
No, sir. RK done first, and then 3-4 years later, LASIK first.
So in that patient, you should treat it like an RK eye because the RK would have debulked the most of the power. So you should treat it like an RK eye.
So the problem is, if you consider post RK calculation, you would get a number which would be much lesser compared to the post LASIK eye. Like for example, for post LASIK calculation, you will get somewhere around 23-24. And post RK you would get around 20-21. So which is almost a 3 to 4 diopter difference. So if you go for the post LASIK one would give you a higher IOL dioptric power. So I just wanted to know from the expert panel, because there would be a lot of difference in the IOL power if you consider either post RK or post LASIK separately.
Can I answer
that? Take both into consideration. You have to choose one.
Yeah. I would look at the axial length very critically. This patient, if he or she has undergone an RK and then underwent a PRK or whatever LASIK, PRK, most likely, that means the correction was either insufficient or the correction didn't take place at all. A lot of times, if the RK was done with 2 superficial cuts, then nothing, flattening would have been very insufficient. If the axial length and the calculated power are kind of something that tells you that this patient's correction with RK was very poor, then you would treat this patient more as a LASIK patient or a corneal laser correction done patient. If the RK gave very good flattening, but it was insufficient, then you would stick with RK calculations.
Just coming, Chitra ma'am, coming to the question what Dr. Anaga asked, I want to ask the panelists here. What we used to do when it's a hard cataract, silicone oil filled eyes, when IOL biometry was not possible. So we can, if the retina is settled, we can definitely take out the oil and we can definitely calculate IOL power with any of the ultrasound method and then going for the secondary IOL implantation. Most of the time, what we used to do is remove the cataract, remove the silicone oil as well, and then it becomes like any other normal routine patient, and then we can go in for the IOL power and then we can do it. Since it's a one eye, definitely he doesn't mind wearing the glasses because it doesn't have much of asymmetry between the 2 eyes. But if it is 2 eyes, then definitely if it's not possible to calculate under the dense cataract and especially under the oil, and sometimes we use heavy silicone oil also, and it will be still more difficult because of the increased viscosity, the sound traveling will be much lesser. So in those cases, I prefer to remove the oil and then go in for a calculation. We can always go in for a secondary IOL power. Panelists can correct me if I'm wrong.
Dr. Anaga, you
Yes,
also have an option of changing the velocity. Basically,
Yes,
the
sir.
velocity is the problem. See, I think you can reset the velocity so that you can probably the correction can happen. So I think in the biometry, we have options. In the acoustic biometry, I'm not talking about optical biometry, we can have an option of resetting the velocity.
You are saying for silicone oil filled eyes, right?
Yes,
Yes.
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 Even in optical biometer, you can feed in the silicone oil mode.
No,
And
it's a
then
mature cataract. No, it's a
Of
mature
course.
cataract.
But it's a mature cataract and we are
So
not.
that is the point. So the optical biometry is not possible because of the maturity of the cataract. So you
Yes.
can reset the velocity, and that would be probably the best bet compared to all the options available.
Yes.
I'll just ask one simple question before we move on to our next speaker. Like between multifocal versus EDOF in post-laser vision correction. Dr. Rohit, could I have your thoughts?
Basically, everything or all the optically, every lens depends on the shape of the cornea you're in. If your cornea has extremely flattened up, if you're treated a -9, then it's a different concept optics compared to a -2. If it's a -2 treated eye and a well-centered one with no coma and minimal spherical aberration, you can do the multifocals. If you're treated a -8 or 9 and created a tremendous amount of spherical aberrations, and if it's a slighter decentration. So if you're planning anything, it's not just SA. Many cataract, I'm sure Himanshu is going to speak about it. Most of the time, you only look at spherical aberration and decide. I think cataract surgeons should look at other aberrations like coma, which helps you to look at decentration. The spherical aberration many times is forgiving, but coma is not. And when you make an incision, you induce more coma, so that your multifocal becomes. So if you have a very low spherical aberration and a small corrected pre-op, multifocal can be done. But if you have corrected a very high, more than 6, and your decentration is not extremely good, then you can think about the EDOF lenses, which helps to give you a better depth of focus. This is my take optically. I mean, saying that it's completely contraindicated to put a multifocal in a post-LASIK eye, I don't think holds good today, especially with so much of new imaging technologies which help you. So 2 things helps us: the amount of spherical aberration induced, and the second is the centration of your laser.
Yes, very true. I think there is no second thought on what he has said. It completes the whole question. I think paucity of time, I'm sure there's going to be a whole lot of questions which will be discussed. We shall go on to our next speaker, and sorry about it, but we'll have to just break the sequence because our VVIP, Dr. Krishna Prasad, has to be moderating somewhere else. So I would have loved to have had him right till the end, and I know you would have come out with very great inputs too. It's our loss. So our next speaker, Dr. Krishna Prasad, is a senior consultant, glaucoma, squint, oculoplasty services. I don't know what he's doing in cataract then, with so many subspecialties which he's manning from Joshi Group of Eye Hospitals, and a very admired figure for his tremendous surgical prowess and academic pursuits to talk on. So here he is going to tell us about the advances in the operative tools like NGT and RTVO. On to you, Dr. Krishna Prasad.
Thank you, Dr. Chitra and the team ARC. I think it's been so nice to be back here. It's so thoughtful of you with all the excellent surgeons honing up their skills, surgical skills, and so much of technology to help them. I think there has been an excellent marriage between the technology and the technique. I think what is missing is to have pushed the boundaries further. It is so thoughtful of you to have this program, because you have been coaxing all surgeons to excel better and better. I think with this to chip in, we also need to see things better. It's not just in the hands of the surgeon or the technology in terms of phaco machines or the femtoseconds. I think it's also to see better. So that is where this talk chips in. It's about, I think this is a very common sight in the OT, like we are struggling to, reach up to the oculars and trying to manage that. but this is how I do the surgery nowadays, okay, where I'm off the oculars, I'm a heads up surgery looking at your large screen, and this is totally a different opinion. So I think sophistication in one's own art is a sophisticated pleasure. However, in surgery, it's a basic obligation. So we have to, as surgeons, evolve and do things better with time to come. I think the first one, the Alcon has commercialized this Ingenuity 3D visualization. That is a new way to look at the ocular tissues and to operate. So we are seeing it better and we are doing it better. And the Zeiss also has a prototype as RTVO 800. It's a first digital microscope from Zeiss, which has all the components. Since I'm a user of Ingenuity, I will probably talk more about that. So let us meet the system. The system has a camera, which is probably the heart of the whole thing. It's a 3D high dynamic range camera, which captures the images. And we have a 3D 4K OLED display, a huge display screen, which can display the images what the camera captures. At the same time, the images can be processed with a high-speed graphic processor. It's simply that you take a photograph and do some photoshopping. It is not just the eye which are seeing, it is the computer graphics. At the same time, you have a passive circularly polarized 3D glasses. So a surgeon, so what is the advantages? Like you have an enhanced depth of field. For example, if this is the picture that you are seeing, you're only seeing things in the front, you don't have the things at the back are blurred. But if you can see everything at once in one shot, it would make a lot of things easier for the surgeon. At the same time, you know different quality pictures, like one is overexposed, other is underexposed. Instead, if you have an all immersive environment where you see everything in the right shade of light. So this is where we have the digital visualization. I think you have known with these standard SD screens, which gave us to enhanced definition, then the HD screen. And now you have the typical home theater feel where you have the digital era taking over the way we see things. So what is very important is when you magnify something, you need to also perform better. With this, we normally lose the picture, but if we can see things like this at this magnification. Similarly, if you're seeing the bark of a tree, if you're seeing with this much detail, probably things look much better. At the same time, when you look through a microscope, you see only the central part. When you zoom it, you lose the periphery. But if you can see everything at once, probably your ergonomics can work much better. At the same time, I told you about the photoshopping. This excellent versatile camera and the CPU and the graphic processors can actually do the photoshopping, can make you see in a much different tone, different hue, different resolution, different saturation. What is very important is we have this professional hazard of our neck and back and the shoulders getting the brunt of our marathon surgeries. There's a movie called MSD, The Untold Story, but this MSD is the musculoskeletal disorders, which is an untold story of surgeons. So we all try to crouch onto our microscopes. We lose the lumbar lordosis, our necks are cantilevering. I think this is an untold misery where we have a lot of problems in our OT. The ergonomics takes a hit. But look at our South Zone ARC person who is actually leaning onto his chair and looking at the screen, doing a complicated vitreoretinal surgery, looking so easy and so nice. I think with the Ingenuity has really come a long way with trying to imbibe all the new things that technology can offer. This is just a comparison between the prototype, the most important or the most the upscale Lumira 700 from Zeiss. So it's just a comparison between the two. Like an Ingenuity 3D system offers around 26 to 48% greater magnification compared to an analog microscope that is Lumina 700, and more than 5 times the depth of focus and around nearly 11 to 43% fine depth resolution. This is just a video to show, like once you are actually seeing it through an analog microscope, when you actually zoom it, you tend to lose the blurring. There's a blurring of this bottle. That means they are in different depths. When you actually zoom it up, you tend to only see this better, not the other way around. But instead, if you're seeing through an Ingenuity system, like even if you zoom it even to a higher level, say I'm zooming it further, still you can see both of them very clearly. So this is the advantage of Ingenuity, where the depth of focus comes really in the way. Similarly, the Zeiss RTBO 800 also has, it can also include the intraoperative OCT. I think Dr. Srinivas Joshi can add on more in the discussion that he has regularly uses intraop OCT. And we also have Dr. Tityal who will be talking about intraoperative OCT in the cataract surgery domain. I think this is an excellent, marriage of technologies where the two things can really go a long way. At the same time, with the Callisto coming into this, we have all the parameters on the screen. So without looking at the microscope, you can even align your toric eyeballs with your Zeiss RTBO 800. And also, it is what is very important is the cloud is the way to go. By all the instruments of your OT talk to each other without creating any kind of problems in communication of the technology. So what is very important is it's a new thing. It is a new impetus for a surgeon to get to the OT and do things better. If you see better without straining your neck and back, actually you perform better. So that is where this fusion of data, I told you, various options, various gadgets in the OT can actually interact with each other. So this is just an example of how we do a cataract surgery. Wearing a posh looking dark glasses, and this is where you can see, I'm just talking about the amount of information that you can see in one shot. You see everything in and around the eye, and you are doing this without, there is a little bit of learning and relearning that is required for beginners, and excellent surgeons do not really take more than a day to get used to this heads-up cataract surgery. I think this is really a boon for vitreoretinal surgeons. The same can be told about even the anterior segment surgeons also. I think the cornea surgeons with an intraoperative OCT attached, it can be a great boon for all kinds of cornea procedures like the lamellar surgeries. So the cataract surgery has really made a turnaround with this. But what is very important here is when you have bad corneas, these are the corneas where we have stitched it up because of a corneal tear, a corneal trauma. Normally, analog microscopes reflect a lot of light. You don't tend to see anything inside the eye. So doing a cataract surgery would be very difficult. We have Dr. Namrata Sharma who has done excellent work on how to do intraocular surgeries with bad corneas. But we call it as window of hope. This is where your 3D visualization, especially Ingenuity system, you can actually see a lot better inside the eye despite having a bad corneas. I think this is a very all immersive environment where everybody is involved in it, and everybody gets a real-time view of what is happening in the OT. I think there's a surgical collaboration. Your assistants will know what is happening. Your scrub sisters the nurses will know. So there is no problem in communicating. There's a good, better communication, a workflow, and there's a learning environment. And I also do, other than cataract, many more things. And this is a great tool to do orbital surgeries because of the area that it can cover. So for oculoplasty surgeries, especially orbital and lid surgeries, this is a great tool. And obviously, if you have trainees around you, residents and colleagues, it's a great way to teach. The surgeon cannot mask
1 minute
anything.
remaining.
Yeah, you cannot really hide anything. Everybody sees what's happening. So you're very honest, you're very transparent, and at the same time, you can actually teach your trainees really what's happening. So this is one of the greatest tools that we see as a training center. But what is important? What about the lag? Is there a lag? We see something and it happens a little later. So I think lag is something, anything that happens, takes less than 60 milliseconds, we will not be able to register. Our brain will not be able to register. So presently the technology has reached a stage where this lag is a non-entity. And as we told, the diffusion of innovation, see the early innovators, early adopters will normally ride the ladder and go up. And the people who do not really fall in or really do not, they become laggards, and this is how it happens. So the story from Nokia, they missed on learning, they missed out on changing. Change is the only constant in life, and they lost their chance of survival. I think that is where we matter. We need to change with time. We need to see things better. We need to use the digital innovation, digital technology to Photoshop or images and see better than what our human eye can see. And that will basically translate into better surgical outcomes for better training. Thank you very much.
Thank you very much, Dr. Krishna Prasad, for covering most of the questions you had, and a warm welcome to Dr. Mahipal for joining us a bit late though. I just wanted to ask Dr. Krishna Prasad or anybody else could chip in. Do you feel that, yes, we are doing good cataract surgery without this facility? Do you think it would have a greater value in corneal procedure or probably retina surgeries as against the others because of the increased depth?
Obviously, your microscope cannot be kind of, delegated to only one aspect. I think it's in an institute. You will use it for your vitreoretinal surgeries. You will use it for corneal surgeries and also for cataract surgery. Majority of our surgeries are cataract. So obviously, cataract you can do very comfortably under 3D visualization. But as a technology, it is best suited for retina and corneal surgeries, especially with associated intraoperative OCT. But once you probably get to start doing, cataract surgeries without looking into the microscope oculars, I think it's a great feeling. It's a great feeling at the back, neck, and once you probably get onto this, it is really, really very, very addicting. At the same time, it is not basically for the patient. Obviously, the outcomes of the surgery may not change much with expert surgeon, whether they do to an analog microscope or to an NGDT or a RTBU. It is basically for the surgeon. I think you have spent a lot of time for making things better for the patient. It is time that the surgeon should also have a due credit to have their, have a more luxurious stay inside the OT and to operate with much better ergonomics. I think that is where this course and probably can justify the cost involved.
Chitra, can I chip in?
Yes,
Chitra,
yes,
can
sure.
I chip in? Because
Yes.
I think I deserve to chip in because I'm the latest entrance into this club. So I just started using this RT 800 exactly for the last 7 days. I'm absolutely thrilled with it. As Krishna Prasad said, of course, it makes an enormous difference for cataract. I didn't believe it would make something for the glaucoma surgeon. We did a few glaucoma surgeries, raising the flap, doing the trabeculectomies, amazing difference. And my VR surgeons are just over the moon with it. There's nothing that, and I don't know about the lag. I don't see any lag with the Zeiss system, zero. It's brilliant. But as Krishna Prasad said, does it really make a difference to the patient? Yes, low light, we use such low light that the patient is very comfortable. Surgery goes on a little faster actually, and suddenly you feel that you're operating in a football field. That anterior segment, the anterior chamber suddenly feels fully expanded and you know exactly where you are doing everything. It's a completely different experience, and in a matter of 8 or 9 days. The other thing where I actually disagree with Krishna Prasad is that there's a learning curve. I put my 3 fellows on it off the bat. They've never seen this product in their life. And they just finished, start to finish their first phaco, no issues. And the junior most fellow had done only 60 phaco so far. And she just went on and just like luck to water, nothing, start to finish in a matter of minutes, and she was out and she was thrilled with it. Their understanding of depth and the field of
KP,
Ma'am, I wanted to
KP,
ask.
I had a question for you.
Yeah.
Yeah, Namrata, come on.
I had a question for you, Krishna Prasad. You have both the systems. You have Ingenuity and you have Zeiss. What do you think is the difference between the two, and which one do you think is better for, which kind of surgery?
So we have Ingenuity and Arul has RTBU. So we both have to sit and answer the question together.
So I think we would leave this. We have also used this machine. I am going to ask Dr. Mahipal this. Do you think this actually has a future potential in
I wanted to ask him only.
So that's why I said.
Namrata, your voice is not coming off clear. I think your network is not good.
I think the Mahipal sir can chip in. I think he has the...
Mahipal sir has been always in the forefront of new technology, sir. So we want to know what is your view about
He's lacking in 3D technology. I don't know why.
Unfortunately, I don't believe in this technology too much, so that's why I have not purchased it or used it. But I don't know, since all of you are going gaga about it, maybe I can.
No, sir.
All of us
Sir,
are
you
not
should
going
you
gaga.
should try, sir. It is here to stay, and I think this is the future.
Great. I think
Just one point I wanted to make, Chitra madam, is
It's like a intro. So it's like a intro diagnostics. You don't have to take the diagnostics part after the surgery. It just happens with the surgery. So I think it is here to stay, and especially for corneal ocular surface surgery, it is a great tool. I think it has really refined all anterior segment surgeries. I can't say about posterior segment because I don't work on it, but all anterior segment surgeries have been hugely fine-tuned by this.
Nowadays, I am laying my hands on the intra of OCT with this ICE microscope. So I think it's great for making presentations, but otherwise it's more time consuming and things like that. I really don't know whether Tityal is laughing.
You need to get used to it, sir.
Laughter has some realism in it.
No, just to answer Chitra madam's question, the Ingenuity was first developed for VR. Yeah, I have to be very frank on it. It was developed for VR. And later on, because the earlier surgery, when you were able to do a cataract surgery, it was always like operating in a well. But now with the CR 1.4 software, which has come just 20 days back to India, and we are using that, and it's definitely looking a lot much better. Secondly, any cataract surgery can be done with even with the upper microscope also. The challenges comes is when you have the adding of the color channels, when you have adding of the light profile, and now it has come out with the temperature bar where you can change from 3500 Kelvin to 7000 Kelvin. And once you are able to do a cataract surgery, good cataract surgery, even a white cataract without using the dye, with the addition of these colors, I think that becomes a kind of changing of the technology. They are working on that, and probably with the now present software, it's going good even with the cataract surgeries as well.
Just a question, Arul, where is Arul gone? How expensive is it now? Have the prices come down?
No, people, you can choose to upgrade on your existing machine, so that way it becomes cheaper. If you want to buy the whole unit, it is enormously expensive.
You will not disclose the buying price, sir.
That's what I'm saying. What is enormous now?
Okay, if you're buying the whole unit, that means you're buying the RTO 800 with the intraoperative OCT, it's almost 4 crores. If you take off the intraop OCT...
Have you bought it with the intraop?
No. I'm sorry. I did not buy the intraop OCT. I did not buy the intraop. I bought only...
But Mahipal sir, to be frank with you, if you are a Centurion lover, you should go with it because it is coming with the integrated cataract suite. The Centurion, all the modules are being put up on the Ingenuity screen, and it will be easy for you to just send the feedback between the Ingenuity with this. Because see, most of these phaco machines are now better well with the Alcon, and with the 3D visualization with them, getting an integrated suite, I think it's always better.
Thanks a lot, but I think we have a lot of good talks ahead. So this controversy would continue. We all know, none of us deny how fantastic the technology is, but we're trying to be realistic. Our next speaker is Dr. Himanshu Mehta, Medical Superintendent and heading the Cornea, Refractive and Ocular Surface in his practice location, NN2. And he's going to be delving on a very quintessential topic, corneal topography and its role play in enhancing our cataract surgeries. On to you.
Thank you, Dr. Chitra. Am I audible?
Yes, yes.
Thank you, Dr. Chitra. My job today is to share my thoughts on why do cataract surgeons need topography, and hopefully I would like to convince them. The topic is basic to moderate. So let's start with the case. A 60-year-old gentleman who has come for the cataract surgery, and the optical biometer shows 1.4 diopter of astigmatism. Toric IOL is planned and toric IOL is performed post-operatively. Unfortunately, you have 3 diopter of cylinder. Now, where the hell was cylinder hiding behind? Now, if you look at the Pentacam scan, and if I focus on the curvature map, if you look at the curvature map here, there is significant asymmetry in the steep axis. If you see one side, The hemimeridian shows 40 diopter K values, the other side shows 40.6 diopter, almost 6 diopter of difference. And unfortunately, the SIM K values of K2 would take average of this thing. K1 also would be average. And finally, the difference between two would be something which a keratometry would take as an astigmatism. So remember, keratometry talks the language of meridians, whereas topography talks the language of hemimeridians. Astigmatism, when we talk about astigmatism, we normally classify as with the rule, against the rule, or oblique. All of them can be suitable for toric IOLs. However, the irregular astigmatism is one which may not be very suitable for toric IOL. Remember, in all such kind of cases, if you do keratometry, you may end up getting some values, but unfortunately, it may not be very accurate. So taking the previous question, which we were discussing about trifocal or anything about such lenses in keratoconic eye, well, keratoconic eye would be highly irregular eye. But in such kind of cases, as Dr. Rohit was talking about, your higher order aberration would not be taken care, and hence any of these lenses do is just take care of lower order aberration, which is sphere and cylinder, and which may not give the best outcome. So yes, corneal topographers are mandatory if you are planning to do any specialized lenses or premium lens, so-called. So when we talk about topographers, we refer to the Placido-based topographer earlier, and they come in different size, shape, different ring size, but all of them talk one language, which is steeper the cornea, warmer the color. Rabinowitz and colleagues, they describe the topographic pattern into 10 common topographic pattern, of which one which we all love to hate is the asymmetric bow tie pattern with the radial skewing and inferior steepening, which is a typical pattern of keratoconus and which every LASIK surgeon hates to see. Whenever we look at the topography, there are certain checklists we look at the topography apart from the details of the patient, good fixation, good exposure, color scale, whether the map is proper, along with comparing with the other eye. Let's see them one by one. One case, a young male who has come for the LASIK surgery, looking at this kind of thing, if we look at the pattern, well, it looks like a friend which suggestive of keratoconic pattern. So, of course, the LASIK is not the best option here. However, if we see the raw data, we see the centration is not proper. So it's a false positive because of poor fixation. Moment we correct the fixation, the topography becomes regular and patient is possibly suitable for the LASIK surgery. Hence, it's a good fixation which is mandatory to see. One more such kind of case, when you look at the topography, you see periphery, there are small dots kind of thing, which actually assumes the topography data there. But if you see, there is a poor exposure from there. So your data coming from such area is not very reliable. And remember, such thing becomes very important when you are doing something like topo-guided PRK for keratoconus and all such kind of cases to regularize the cornea before you perform any cataract surgery there. So good exposure of the cornea is very important. The color scale changes the way keratoconus looks, or color scale changes the way topography looks. So it's very important to know what color scale you are dealing with. Also, the maps like axial curvature map, tangential curvature map, these maps, same cornea may look very different. But what axial map does is it gives you a pattern diagnosis and very easy way to diagnose, whereas tangential map gives you more of a localized abnormality in which can be accurately detected. So please make sure you look at the map. Also, something called enantiomorphism, where most of the typical topographies have mirror image, which is imperative to see when you are seeing both the topography. So keep both the eyes topography printout next to each other and confirm whether they are comparable with each other. So if the topography is so good, why do we think of something else higher than the normal topographer, which is tomographer? Let's see a case here. A topographically normal eye, which is sent to us with a compound myopic astigmatism, where the pachymetry values done on ultrasound was normal, 500 micron. And you can see the topographic picture, which we earlier saw, looks like with the rule astigmatism in both eyes and looks to be fine with 500 micron pachy. Having said that, when we look at the pentacam values here, the thinnest point is not in the center and it's 470 micron. Posterior surface is not looking normal. And this is not a case where I'd be very keen to do it in a LASIK surgery. Rather, I would do a lens-based surgery in such kind of cases. So if we do not have an elevation-based topographer, we would have missed such kind of thing. And that's the role of elevation-based topographer here. Placido-based topographer, they give real topography from the first Purkinje image or the tear film, whereas it does not give you data from the posterior surface and the entire corneal surface. Whereas elevation-based topographers can give you the entire anterior segment topography, which is much more accurate. Whenever we talk about elevation-based topography, the topographic patterns are usually two. One is the island pattern, and second is the saddle pattern. Island pattern normal is a prolate cornea, or where there is a mountain in the center, which is very typical of a pattern of keratoconus. So if you see here, this is typical pentacam map. The first map is curvature map, which we know that there are 10 patterns. The second map here is anterior elevation map, two types of pattern, whether it's an island or the saddle pattern. The posterior elevation map there, again, two types of pattern. And next comes the pachymetric map, which is self-explanatory. If we see an example, we go one by one. First, the data from the patient, the K values and quality score. Next, we go to the curvature map and we know 10 types of pattern. What we see here is radial skewing and inferior steepening, which is typical of keratoconus. Then we go to the anterior elevation map, two types of map. Here we see the mountain or the island in the center, which is possible in keratoconus. The posterior elevation map also shows a mountain in the center, again, typical of keratoconus. The pachymetric analysis shows that it's 490 pachy with a Kmax around 54. We are dealing with nothing but a keratoconus. Very simple. So even though these are newer machines, they're still quite simple to do. There are certain other benefits of such kind of topographer. Well, for the cataract surgeon, it tells you about regular, irregular astigmatism. It helps you to detect keratoconus, pellucid margin degeneration, helps you to see the IL power calculation, as Dr. Chitra was talking about in LASIK patients. It also tells you about the spherical aberration or asphericity of the cornea. It gives us a story about angle kappa, angle alpha, and sometimes it also can help you to grade the cataract and along with the outcome of your toricity. One such advantage of one such instrument like eye trace, it can tell you about the angle alpha, angle kappa. Well, why is it important? Well, we know that very significant high angle alpha can be poor candidate for multifocal, which will possibly lead to glare and halos.
So
another
such
kind of thing, I shall be finishing pretty soon. Another such kind of thing which can be dysfunctional lens, which can help you to see the irregularity in the transparency of the lens and can help you to diagnose cataract much earlier before anything else goes. Another interesting thing which Pentacam does, it gives you a zonal K values, which is extremely important in detecting the IOL power, especially post-refractive surgery. Adding all these things into the calculator can give you tremendous outcome. Not only this thing, certain topographers can actually give you a detailed anterior segment analysis and can be used for a comprehensive dry eye workup platform also. Pellucid margin degeneration, which gives a very typical against the rule astigmatism with a typical kissing bird sign or butterfly wing pattern. It's very important to have your topographer. Hence, you can put a high toric cylindrical power, and topographers like iTrace can actually tell you a story that how much quality of vision improves in these cases. It also can show you the outcome of toricity and whether it needs to be rotated and how good outcome it can give you. To summarize, corneal topography is mandatory before any premium IOL, especially toric and multifocals. Newer elevation-based topographer can image the posterior surface of the cornea also, and topography machine along with the other frills can bring us tremendous value in cataract surgeons practice. Thank you very much.
Thanks a lot, Himanshu. As always, you have covered just absolutely everything and leaving us very few questions to ask you. Just some of us could have this curiosity, like, would you be able to use the EKR value in any other formula other than Holiday 2? Is that possible?
I would definitely agree that you can use EKR. So EKR is not a formula. Basically, it's an equivalent K reading comparing both anterior surface, posterior surface, the refractive index and everything. So what it has done is it gives you a zonal K reading in these areas. So it certainly does not mean that you need to use only Holiday formula. In fact, the same reading you can actually fit into your ACRS calculator as the different topographic K reading into 0 millimeter, 1 millimeter, 2, 3, anywhere. So yes, of course, what it does is it gives you a liberty to analyze your K values in different zones and still tell you the entire story in a glance.
I'm not very sure, unless you are very sure. I felt that it has greater application in Holiday 2, though I do not have, at this point of time, not remembering the points to substantiate that. Of course, what you say makes sense, but it is just a thought. Is there any specific data which you can take from a topographer to incorporate into IOL power calculation? Or is it an impression of the topography which helps you decide which IOL technology to go in for?
Okay, so one interesting thing, remember that the keratometric values which you get on an optical keratometer or your manual keratometer versus the SIM-K values which you get in a topographer are not same. They cannot be comparable. Now, in your hand, whenever you do any surgery, whatever we call surgeon's hunch or surgeon's factor or your correction, which you slowly evolve into, would be totally different when you drop of head change the K values from your biometer to directly a topographer. Yes, if you start using topographer for every case of yours, you may ultimately get your outcome optimized to the level that you are fine. But at drop of head, to calculate your spherical power, if you use your topography machine, may not be the smartest idea. Having said that, for the toric IOL, to know the toricity or to know the what power you want to take, how much difference, how much cylindrical power you want to take, you can use either of them. It's absolutely fine, because there, when you enter those values, your toric calculator just uses that to know how much astigmatism you are going to correct. Now, for that, if you are very sure and if you're very comfortable with your topography, you surely can use that. But to calculate your spherical equivalent, I won't say would be a smart idea.
Yes, very well answered, Dr. Himanshu. I wanted Dr. Rohit Shetty to tell me this. Since you have a setup where you have all the topographers with you, which would you suggest as the most comprehensive to be used for a cataract surgeon? Dr. Rohit?
I personally feel, I think Himanshu showed all from the Pentacam, or any modern day shine plug based imaging would be the best way, because any Placido, especially these are elderly people, and a lot of them have ocular surface issues, so it may not get a very proper value. But moving forward, I think the best topographer would be a OCT based, especially because it has very little artifacts as far as we see what we see with these topographers. And the most important thing with the OCT based hybrid topographers today is it helps to give you epithelial mapping. Like Himanshu said, those one area flat and the other area steep. We don't know at that point of time whether we had epithelial mapping. That could be an epithelial changes itself. And especially in this elderly population, we see a lot of changes. And epithelial irregularity is an indirect marker for an ocular surface disease itself. So way forward, I think epithelial OCT based, but at this point of time, any modern day shine plug or combination of shine plug with Placido would do.
Yeah, thanks a lot, Dr. Rohit. That was exactly what I wanted to hear. expert panel, do you all have any thought to share? Dr. Mahipal, you would like to bring up some point when you're talking on topographies before you go on to the next talk?
No, I think Himanshu, a great talk as always. One needs to have the concepts of a topography or the keratometry of a particular patient, because nowadays we are looking at making the cataract surgery into a refractive surgery. So what is very, very important is that if you are going in for premium lenses, then I think the trifocal lenses are coming of age. And if you have to get a correct power and nearer to emetropia, because that's what we are aiming for in all these trifocal lenses, then under those circumstances, the correction of astigmatism becomes something very, very important. And that is where the topography does. And normally I would say that in case there is a difference which is of significance between a topographer and an IOL master / auto ref keratometer, then I would be very, very diffident in going in for a toric lens, especially in those cases, because then you really don't know. And these are specifically in cases where patient may have a keratoconus or something like that, and you have done a cross-linking and you want to do that. So if there is a big difference, you need to analyze that particular thing and decide whether you actually want to be very, very sure to go in, because the demand of the patient becomes very high. So the topographer will give you whether there is symmetry, there is asymmetry, whether the posterior float is this thing, and TK value, etc., that you are getting only in the IOL Master 700. Either you use that or you have the nomogram for standardization with the posterior float. That needs to be done. So all in all, I would say even ocular surface anomalies, which Rohit has talked about, that is also a very important thing that nowadays you can find out with the OCT-based hybrid topographer, because that is where the patient remains rather unhappy. So all these things in premium IOLs is really upping up the outcomes, and that is very, very important. One other thing which Himanshu said, I think in India we've still not moved on to, a lot of people don't have the eye trace, but I think dysfunctional lens syndrome is something which is very, very important, and I think that is going to be the future tomorrow, where patients are complaining of some problem in their vision, and normally you see on a slit lamp and say, no, you don't have a cataract, and come after this thing. But if you put them on an eye trace and you find out that there is a huge amount of abrasion, the contrast, the quality of vision has gone down, then you can tell them and show them on the eye trace that this is what is happening. And if you put a new lens, this is what is going to happen. So I think these are obviously the updates or upgradations that all of us will soon have to have in the practice as we move on to premium practice. And topography also, I think toric lenses are now gaining. The only thing is I have been fighting it out with the manufacturers that they should have a separate price for low toricity versus high toricity, so that even a person who's coming with a 1 diopter toric can go in for a toric IOL, because that really changes the outcomes for a patient. So topography, I think, is mandatory, specifically in the premium IOL patients that you are looking at.
Yes, wonderful talk, Dr. Himanshu, and very well summarized by Dr. Rohit and Dr. Mahipal. Lot of things brought out. So I would want you to stay on for a bit more, Himanshu. We can deal with the Ganesha later. So going on to our next speaker is Dr. Pooja Kamar, a leading young light of the NN Group of Hospital, Consultant Cataract and Refractive Services, with innumerable awards and accolades to her credit at such a young age. And she is going to take on a very important topic, ocular surface and its impact on patients undergoing cataract surgery. On to you, Dr. Pooja.
Thank you, ma'am. And I would like to thank you and the entire team for having me here. At the outset, I have no financial disclosures on whatever I'm going to be talking about in this presentation. So let me start with this case, a 78-year-old male patient who came in for a cataract surgery for left eye. His other eye was operated, pseudophakic operated elsewhere. He showed a -3 diopter of sphere improving to 618 and had NS3 grading on slit lamp evaluation. When we did his IOL power, biometry, we found that, the only thing which was not matching, that he showed up an astigmatism of 4.59 diopters, which was like something not matching, because the other eye had a monofocal lens, non-toric. And so we decided to repeat the scan after 3 days. And when we repeated the scan after 3 days, then we saw that, the astigmatism from my 4.59 has come down to 1.84. So what was really happening here? Why was there such a huge change in just 3 days? What we retrospectively found was that the patient had dry eyes, and on top of that, patient had undergone GAT. And after that, we had done the biometry, and that is why there was such a gross difference, which was, which could have led to this issue of high astigmatism. And we would have probably, if not looked into detail, we would have probably put a toric oil for this patient and landed up into a refractive surprise. So these are the conditions, like, it's not just a preoperative ocular surface issue which we are dealing with, but the cataract surgery can also lead to post-operative ocular surface changes, which can make patient's life miserable, and also unhappy patient post-refractive surgery. So what we have to deal here is we have to deal with preoperative, intraoperative, post-operative, and also study the long-term impact. So I would start from the preoperative impact, which already Himanshu sir has given a beautiful talk on corneal topography. And on and off multiple times, the role of corneal topography and ocular surface issues have been dealt with. So we have to be very much careful of, like, when we are doing the topography, what is the ocular surface condition of the patient. If the patient has dry eye, then we have to treat the dry eye or ocular surface condition and then do a corneal topography for a reliable result. The second thing, we had a wonderful discussion about the newer generation microscope for cataract surgeries, where we said, okay, it's a phenomenal thing. But if the preoperatively the MGD has been missed, or if it has not been picked up correctly, then whichever good microscope you have, intraoperatively this undiagnosed MGD can have a lot of debris on the ocular surface, which can impact, like you can see here, which can impact the visibility during the surgery, and it might not have a very good outcome. So that is also very important to deal with a preoperative dry eye to avoid intraoperative issues also. Post-operatively, let's see this case. This is a patient, normal corneal findings, grade 3 cataract in left eye, again, normal fundus examination. Epithelial thickness was normal, normal tear film metrics. We went ahead and put a multifocal IOL in this patient, both the patients. If you can see, both are well-centered multifocal IOLs. But post-operatively, one patient was happy with 6.6 and 6, no complaints. But second patient was extremely unhappy, 6.6 and 6, but persistent complaints of post-operative glare, which was not resolving with any of the treatment. Also, we gave patient 6 months for the neuroadaptation, but it did not improve. So what we did, what actually happened here, we retrospectively went back, we do ocular optical quality analysis system for all the patients undergoing premium IOL surgery, and we found that the second patient was unhappy, had pre-operatively a poor tear film to begin with. Even though the dry eye tear film metrics were normal, but the tear film quality was poor, and that just exaggerated post-surgery, and that's what made the patient unhappy. And you can see here also that this is a vision breakup time. At just 5 seconds, patient's visual quality is extremely dropping, and after the blink, it's again improving. So that was explaining why the patient had consistent glare post-surgery. So as it was a gross and a exaggerated response, we did the vector pulsation therapy for this patient, and post-surgery you can see how the vision breakup time and the quality of vision for this patient has improved. Again, highlighting the point and the importance of optical quality, which we should check before surgery. Now, Mahipal sir and Rohit sir have already spoken about the OCD-based topographers. So I just want to give a small example here about the role of epithelial mapping, which in cataract surgery. It's still emerging, but I'm sure that is going to be a future, because as we are emerging a lot into premium IOLs, we would have to look at this small changes as well. So let's again, normal topography, we went ahead and did a cataract surgery for the patient, but one patient had a good outcome and the second patient had a poor visual outcome. So what was happening here? Why did both the patients with normal topography had different outcomes? So we went and saw that, the lower and higher order aberrations for the cornea were absolutely normal. No change in coma, spherical comas were also within normal limits. But when we dug deeper, we found that the first patient's epithelium was normal with any epithelial aberrations present, but the second patient had abnormal epithelium with, if you can see here, there are epithelial aberrations present with higher coma in just the epithelium and not the cornea. And we did a cataract surgery for the patient, and post-operatively, the first patient had again normal outcome, but the second patient's aberrations had just gone worse because the epithelium remodeling was not optimal, the wound healing was not optimal, and that's why the post-operatively the epithelial remodeling was not accurate, and the aberrations just went higher, and that's what was making the patient unhappy post-surgery. So right now we are just looking at, if poor meibography, unhealthy ocular surface, we don't do, it might be leading to unreliable, steep or flat K values and poor quality of vision post-refractive surgery. But what we'll have to look further also is the irregular epithelium for these patients, because that is also a point to where we are seeing, an unhealthy ocular surface, because an unhealthy ocular surface or epithelium can lead to a lot of glare halos post surgery. So right now what we see is we just see the corneal aberrations, the anterior, posterior, and the total, and decide whether to do a premium IOL or not. But of course, in future, we will have to use the OCT-based topographer as already highlighted, consider the epithelium, and then decide whether to do a premium IOL for these patients or not, or whether to treat the patients or not. Long-term problems, yes, there are long-term impacts. There have been various reports that if you don't treat the dry eye or ocular surface conditions at the right time, it can lead to depression and anxiety for these patients rather than the patients who do not have any complaint. We do have current modalities, but sometimes it does not work. We have to look further. So role of cyclosporin, it's just not for dry eyes or refractive surgery. It's emerging in after cataract surgery as well. So if you feel that patients have ocular surface issues, then you can definitely give cyclosporin for these patients for at least 3 to 6 months post-surgery for an optimal outcome. What we do here is, if preoperatively we find that the patient has ocular surface issues, then we treat the patient aggressively, wait for 4 to 6 weeks, and then take the patient up for surgery for optimal outcomes. If it's on the higher side, we do one of the newer treatment modalities like vector pulsation therapy or intense pulse light therapy, in addition to the conventional management to help the patient overcome and have an optimal outcome post surgery. So do we need all the tests for all the patients? Of course, new patients do need a detailed history, T-bud and eyelid examination. But if you feel that patients are at risk, then add a questionnaire, grade the staging, do tear film meniscus and breakup time, meibum expression testing, and if it's high risk or uncontrolled, do add a meibography also for this patient. What we have started doing and what would be the future is point of care diagnostic kit. Now, a lot of times, and this is just a ELISA based kit, it's just like your glucometer kit where you can measure the tear markers in your clinic. You don't need to go to a lab. But you can just have a Schirmer strip in your kit and measure the tear markers. Why would you need it? As I said, it's just like your glucometer kit. Now, there are a lot of patients who post-surgery complain of chronic itching, chubta hai, chala nahi ja raha hai, whatever treatment you give, it doesn't go off. A lot of discomfort, pain without stain, inflammation, which leads to poor wound healing, irregular epithelium, and which might lead to poor optical quality. And if you have done a toric IOL for this patient, it might land up in a refractive surprise or a poor quality of vision or regression as well. So these are the patients whom we are dealing with. They have a lot of nociception in the eye, a lot of abnormal markers in the eye. So that is why if we can measure it with this diagnostic kit, we can customize the treatment, because not everyone will need a cyclosporin or a tab doxy or a steroid. So if or
Ma'am, you
a
have 1 minute remaining.
therapy. Yes, thank you. So if you have a tear diagnostic test in your clinic, we can measure the markers which are abnormal, customize the treatment for this patient for an optimal outcome. I would like to thank my entire team back at Narayan Netralaya for this years of work, which I'm presenting today in front of all of you. Thank you.
Thank you, Pooja. That was a very interesting talk. As always, all the information was there. But I think one tip we take from here on is that before we do a biometry for our patients, probably we should not do any other contact procedure before that, so that we are able to better assess the thing, because these itself could trigger off an irregular Maya. So what would you tell your technician, Pooja, to look for when we are doing the examination, a biometry, and the other things related to cataract procedures?
So, ma'am, one of the most important thing when you're doing a biometry or you're doing your IOL master or anything, always do it first. It should not be a test also where, like, even if you have done a dry eye evaluation like Schirmer's test, it would alter the results when you're doing a biometry. So if your patient has cataract and is planning to undergo cataract investigations, then that should be the test which should be first always. And whenever they are doing the scan, they have to enter the exposition, the quality of the Myers which they are getting, and the centration, the red dot light, whether it's point or scattered, and that's how we we train our technicians to do that. And if they find any abnormality, they have to come and tell us right away, because a lot of times if they don't tell us or they don't report back to you, then it can be a problem. Yes.
Ma'am, I wanted to ask one question. Dr. Pooja, what is your take on the role of chloroquine eye drops on management of dry eye?
Sir, personally, we have used chloroquine eye drops and trehalose based eye drops and cyclosporin as well. What we found was that the best drop to use would be cyclosporin or trehalose, because chloroquine is still not accepted extremely well for the patients. The compliance is poor. There's a lot of stinging, and the improvement is not as good as what you find with cyclosporin or trehalose. So
I think adding to what Pooja said, even that fishtail kind of appearance on the those dots on the optical biometry, and also if your standard deviation is also way off, besides the irregular margin, that is also an indicator to consider dry eye. I wanted to ask Dr. Nitin this question, and also Dr. Rohit to add to it. What would you, in the ocular surface disease like a dry eye status, nothing more complex, for your cataract surgery patients, what would be the steroid regime, the NSAID regime, or the lubricant regime would you ask in your practice, Dr. Nitin?
So, just like Pooja said, we follow the same regimen. Basically, the first and the foremost thing is, before any patient undergoes any test of any other sorts, we see to it that at least the keratometry is taken, because that is something which makes a lot of difference. So even before any eye drops are instilled, any dilatation is done. Again, when you ask what you tell the technician, one other important point I would like to make here is that also look for excessive meibomian secretion. Sometimes you have excessive meibomian secretions on the cornea, and you can get way off readings on your keratometry. Regarding the regimen post-op, well, a good lubricant right from the beginning, along with cyclosporin, is what we follow. The steroids, we normally start with prednisolone right from the post-operative, in the first day post-operative. And the steroids, we would not change the normal regimen even for a dry eye patient, unless we find that there is no improvement in the dry eye scores, in spite of having the lubricants, trehalose-based lubricant and cyclosporin. Then we would, after tapering the prednisolone, then probably add a surface-acting steroid like a fluoromethalone or a notepretinol for the next month or so.
Dr. Rohit, your thoughts?
Ma'am, what we do is we track them. We use an algorithmic approach when you're using a lubricant. For example, if the patient has a predominantly evaporative-based dry eye, and if the T-BUT is less than 5, then with a lot of OSDI, and OSDI also really helps because it tells you that there's a lot of inflammation. These patients are the ones who would, and you see changes on the lids. You see a lot of telangiectasias, capped glands, and these sort of stuff. You would, I would prefer them a cyclosporin to start very early, along with the steroids, whatever you use, because when you actually taper the steroid, the cyclosporin would have started working. And these patients, if they have a lot of ocular staining, if you have SPKs or those kind of staining, and less than 5 is pretty not very good. So these would do very with trehalose with sodium hyaluronate based drops or hyaluronate based drops. But if the patient has a T-BUT more than 5, and then they are relatively not as symptomatic as per the OSDI, and the no lid changes as such, then you can look at, and especially if you're used a multifocal lenses, if you're using a sodium hyaluronate based drops, they would experience more scatter. These are all highly viscous. So you would use osmoprotectant kind of drops. Anything you use other than hyaluronate would be osmoprotectant, because there's a lot of osmolality changes in your tear film, especially after you use betadine and a lot of paracaine during your topical phaco. A lot of topical phacos would change a lot of osmolality, especially the pH. So these would benefit from an osmoprotectant drops of whatever whatever is available now. So, and steroids would not really change much, but now they have options of iLight, EI, and also LipiFlow. even pre-operatively and post-operatively. And these are all, especially post-operatively, because the eyelid and EI does not really involve any pressure on the eyes. Still, I would think that, you can consider this at this point of time. So you can triage them according to the symptoms, the signs, the changes on the lids, especially if they have a lot of lid changes. Those people are driven by MMP9 activities. And these people, you have to start them on cyclosporin. Because and these with the short course of ointment, of course, but the lid changes are a significant indication of an MMP9 activities, and cyclosporin works very well.
Namrata, Dr. Namrata, what would you talk about non-steroidal anti-inflammatory? How long would you use this in these mild dry eye patients?
No, I don't think I would use non-steroidal anti-inflammatory drops at all in these kind of patients. Because for one, that NSAIDs as such are known to cause corneal melts, and two, they do have some effect also on increasing the dryness. So I think as soon as we have a patient of ocular surface disease, non-steroidal anti-inflammatory drugs is a no-no for them.
Thank you, Dr. Namrata. I think it's a wonderful talk, Pooja, and great discussions. Unless Anaga or Satyajit want to add anything.
I have one question to all the panelists.
Yes.
Now that we are looking at so many additions that, what all of us are doing in the cataract workup, like it's not just biometry, like optical biometry, we are adding dry eye workup, we are adding OCT, then we'll be adding topography and tomography. So what is the routine charges? This is off the this thing. What are the routine charges of a cataract workup for a toric IOL patient, for example? Do you charge for everything, or it is just a...
No, we don't charge for everything separately. We don't.
So this is all free of cost, right?
Yeah.
Huh?
And
Yes.
Anaga, we don't charge for anything, Anaga.
So you cannot, I don't think you can make money on that in your new hospital, Anaga. It just adds to the quality of your practice by diagnosing all those issues and treating them along with, I think.
But one thing is definitely there, Chitra, it happens with refractive patients more frequently. They'll get all the tests done from you and then, get operated elsewhere. So I think some charges you should, take beforehand only before just taking OPD consultation charges.
We have a package.
We have a
workup charge.
We have a package of 4,500. We call it as pre-cataract workup, and that's the IOL master. Plus we have a specular, and plus we have an OCT. So these three things we charge 4,500, and OSA, if it has to be done, it will be charged separate.
Yeah, I think that makes sense. Maybe we'll have to get
because what Namrata is saying is very correct, because people take because you give them, there are some hospitals who don't give the investigation, but obviously if you give all the investigation, quite often they go to some other place where they don't even have an IOL master 700. So I have had one or two practices referring the patients to me, not referring to me, but saying the patient, "Aap bahan kara lo, IOL master 700 humne kar diya, wo leke chale gaye," and they got the surgery done at the other place. So there are people who are smart enough. So you need to charge because you have already paid for a huge sum for getting a higher degree of.
We in Patna charge 2,500 for all the things that Maipal sir has said.
Yeah, so you need to charge something. That's what I'm saying.
Yeah. So we go on to our next speaker, Dr. Samresh, who is leading the Raghudeep Eye Hospital at Jaipur, a young dynamic surgeon with a clear insight on the latest technologies offered in cataract surgery. And he's definitely going to throw a lot of insight into this complex topic. On to you, Samresh.
Thanks a lot, madam. I would like to thank the ARC for inviting me for this talk. And I would like to acknowledge that a lot of knowledge that I've gained up until now and that I continue to gain comes from Narayan Netralaya and Dr. Rohit Shetty's guidance. And he's always been inspiring. Apart from all the panel that is sitting over here, they've taught us so much. So I'm just going to cut it short and move on to clinical scenarios. But just to get the background going, when we talk of aberrometry, we essentially talk of wavefront aberrometers. And a wavefront is a line that bisects the parallel rays of light. So if you have a straight parallel rays of light, you have a straight plane wavefront. And if you have a converging array of light, you have what is known as a spherical wavefront, which is essentially how a wavefront would move inside the human eye. Any deviation from a normal wavefront would be an aberrated or an irregular wavefront. And what we discuss at times is irregular, aberrometry is used to pick up these subtle things that go way beyond myopia and hyperopia. So what are aberrations? Aberrations errors, just like the refractive errors that we've always known, like myopia, hypermetropia, and defocus, but it's just beyond that. So once you correct the hypermetropia, myopia, and defocus, what is left is higher order aberrations. It's something that we don't routinely discuss because in our routinely clinical practices for our refractions, there are no ways that we can, in a routine clinical practice, correct these higher order aberrations. So aberrometers are essentially just super autorefractors that pick up all these details that are otherwise missed by normal diagnostics. I'm going to base my talk on a particular aberrometer called an eye trace, which is a combined aberrometer and a corneal placido topographer that Dr. Himanshu sir has brought about. But most aberrometers will give you a plethora of knowledge in part or the other. Just a very quick orientation. The eye trace aberrometer contains ray tracing aberrometry, where it sequentially analyzes around 250, 260 points of light to check where the light goes and hits on the retina, crosses the eye. And it also, since it has a placido topography, corneal aberrations can come out of placido as a derivation. So the placido will give us the placido rings, will give us a curvature map, and from that we can decipher the aberration profiles of the eye. But since we've done so much in our medical practice to know about the cornea, I think it makes sense to know because the eye is like a camera. So only one lens wouldn't do. You have to understand how the inside lens or the actual lens in the eye behaves. Once you get a total aberration profile of the eye and you mathematically deduct the corneal aberrations, very interestingly, what surfaces out and what we've missed for so many years is what is known as the internal aberrations of the eye. Or in simpler words, anything that arises from the corneal tear film onwards is an internal aberration of the eye. Since the machines have very, very sophisticated softwares, they also tell you, and they can also simulate the patient's vision, which is again a very good tool to counsel patients. So just to put address the elephant in the room first, there is something called angle alpha, which Dr. Himanshu brought about also. And what is this angle alpha? You have a few centers in the eye. The center of the limbus, which is the blue cross, the center of the pupil, and the visual axis. Now, these three may coincide or these three may not coincide. When you place a lens inside the capsular bag, you essentially place a lens in the center of the eye because now if your pupil moves a little away or if your center of limbus is off, then the lens is obviously decentered. Now, if you notice over here, the visual axis is somewhere here, but the center of the lens is somewhere here. So where the patient is seeing is not actually from the center of the lens, but from one of those rings in a truly refractive lens. And this difference between the center of the limbus and the visual axis is what is known as angle alpha. So if it's a large angle alpha, it's simple to understand that you're not going to see from the center of the lens, but from one of the rings. But in all honesty, in my clinical practice, I did this for the first 4 or 5 years, but I've now sort of given up on this because in Indians with small pupils, it really doesn't play that much of a role in a real clinical scenario. While it may in some cases, in most cases, in my hands, it doesn't. I'll discuss a case of a very, like Dr. Mahipal sir had brought about. This is a young female who's come to me. She wants to get LASIK done. She's got a very low myopia, but she just can't drive at night. So I dilated her. And I can see small cortical spikes in the periphery, but essentially the central visual axis is clear as it could be because I couldn't see a cataract on slit lamp examination. When I look at the aberrometry, the total eye aberrations show a huge spherical change and some coma. But interestingly, nothing is coming from the cornea. It's all coming from inside the eye. Now, what is inside the eye causing this? So let's see how she's seeing. So if I look at her in a mesopic condition, and I would encourage all investigations, topographies, aberrometries, even refractions to be done in a dimly lit room because that is where you test the patient's performance. We tested her in dim light and her pupil opened up to 5 millimeters. And this is what the patient sees as is simulated by the machine. And as you mathematically drop down the pupil, she becomes crisp. And this is what we checked in our clinic, 6 by 6 in a brightly lit refraction room. And this is what she was when she was complaining of driving issues. This is essentially a cataract information. It's something that Dr. Rohit coined a term called ZOX or Zernike optimized cataracts, where a cataract is actually building up. But we must understand that a cataract builds up as soon as presbyopia starts to land in. Because what else is presbyopia but hardening of the proteins, which eventually will lead to a cataract. The machines learn from it, the software got upgraded, and now you have diagnostics, and now you have algorithms that tell you how much of your lens is opacified, whether your clarity is 100%, which is blue, or it's opacifying, and thereby you can pick up mathematical cataracts before they become clinically apparent to your trained eye. So it's a good tool to pick up early cataracts, preclinical cataracts. Another place where I often use it is in cases like this, with a classical age-related cataract and a straightforward astigmatism that needs correction. So I advise a toric IOL. But the patient is very, very stern because the patient doesn't understand what a cylinder is, has never worn a cylindrical correction. Now the seniors will understand, but this is really interesting. If you look over here at the patient's refraction, the patient's refraction has no cylindrical correction. If you notice, total aberration is no cylinder. But there is a corneal cylinder hanging around, about a diopter of corneal cylinder, which is seen over here. But the beauty of optics inside the eye, the lens inside the eye is nearly completely cancelling out this astigmatism. Blue is in one direction, red is in the opposite direction, giving rise to a no cylindrical correction at a glasses plane to the patient. Once I tell the patient that once I knock off this cylinder, this one is going to manifest here and you land up with the glasses, the patient is quick to adopt a toric IOL. And it's a very beautiful tool to address that same situation. So if you, if you use the right platform of toric IOLs, this is how you can post-operatively see. This is the corneal astigmatism in another patient, and this is the internal astigmatism or the internal astigmatism aberration of the induced aberration of the lens, which nearly completely cancels off, giving rise to a pristine post-operative outcome. It couldn't get better than that, but this also builds up confidence because you can see it and the patient can see it visually as well. So this is another case scenario of a toric IOL, and sometimes overconfidence gets the best of you. So this is what happened to me. I had a patient with a straightforward 2 diopters of astigmatism, no-brainer, toric IOL. The lens star gave me a toric IOL axis, so I don't really do much more diagnosis. I rely on the data given by the lens star. I implanted the lens in the right axis, and I still land up with an astigmatism profile in the patient's eye, and the patient is not happy. This is again where diagnostics will come to use. So I put the patient back on an eye trace. I did the refraction. So this is what it shows. Refraction is green, but it shows a cylinder. But there's a beautiful tool that tells you that I misaligned. Like I said, sometimes overconfidence gets the best of you. So I was supposed to put a lens in another axis, and I put it at 155. And the machine is very nice to tell you that if you rotate it 33 degrees in one axis, you will change 2.25 diopters of cylindrical power, dropping it down to what your target would have been. So this is from yesterday. So Monday, I take up this patient, re-rotate, and I hope this does the trick for me. So again, easy tool, no brainer. You don't have to use too much of your mind to it. Again, optics is something which we oversimplify when we say it's the cornea and the lens, but sometimes it may not be the case. Now, this is a patient with very obvious gut-tape changes. See over here, very clinically visible gut-tape changes. And your surgical mind would, drive you to use proper viscoelastics, low parameters, shallow, sort of slow phaco using a low bottle height. And we did a good surgery at that over years of training. And the patient was a clear cornea, but unhappy at 2 weeks post-op. This was
1 minute remaining.
All right. So this is first post-op day. But we realized that in this case, it is not the lens that, that would have cleared the problem, because it's the gut-tape that are lying in the way of the visual axis that are causing this immense scatter of light, causing blurring to the patient. And so sometimes there's no solution. But if you knew gut-tape would cause refractive changes, I would counsel the patient that it may be a good idea to go ahead and expect, poor vision. Now, just the last case scenario, patient came to me, unhappy multifocal. There's a good restore in the eye. Patient wants a monofocal in the other eye. But when I dilate the patient, you realize that part of the lens is in the bag and part of the lens is lying in the sulcus. Now, what difference would a lens half in the bag, half in the sulcus make? And very interestingly, it would make a huge mountain of difference. So if you notice, this is just a diagrammatic explanation. This is the same patient's UVM. Notice this is how the lens is placed. And the lens is essentially tilted. The moment a lens tilts from his vertical axis, it induces a very, very nasty aberration called a coma aberration. And coma is something you can't clear with glasses or contact lenses, particularly the one that arises from inside optics of the eye. Maybe a corneal one you can. So all we did was we went inside, dissected the capsular bag out, put the lens inside the capsular bag, and the patient became a happy patient. So I'm going to cut this short in the interest of time and just bring about something that I've just recently started using. is I've just started to use this for the hyperometers for measuring the accommodation. So this is a dynamic accommodation of a patient with distance fixation, and this is actually company slide, but just to show you, we can actually in machines like these measure true accommodation and the accommodation reserves of the patient. So so hyperopia plays no role in accommodation. So actually a young patient, about 30-year-old, would accommodate to about 3 diopters, which is something that we all would know. So it's got a very useful range of vision. Compare it with a 48-year-old and you can make out the accommodation reserves are really low. But this comes to cataract practice use now all the more because there are so many different types of lenses which are coming up. And we are really moving into a new era of from breaking down the light to dividing the light to, with EDOF lenses so that you have a huge range of vision. I'm just going to skip through this. So now you can actually put these patients on these hyperometers and really test your hypothesis to see how much is your useful range of vision. Is this lens actually performing? These hyperometers never perform that well with diffractive lenses, but I'm really keeping my fingers crossed to understand how I can use them for my EDOF lenses and to see whether I can deliver more to the patients by tweaking the other eye after I've done one, by using mini monovision, or by just simply going ahead and advising these lenses as my primary treatment plan. So just to finish up, I've used these machines for patient workups, for treatment planning, most often for counseling. And I use them every now and then for unhappy patients, mine operated by me or elsewhere, because most often the problem is not in the surgery. It's a problem in trying to figure out where the trouble's coming from. But like Dr. Himanshu had very beautifully put up, and this I will never forget, these machines will help you tell a story to the patient, and thereby it also adds value to your practice at all times. Thank you.
Thank you, Dr. Samresh. That was a great talk. But don't you think that nowadays with a larger optic zone, which is there in the multifocal IOS, this angle alpha is not such a disturbing factor as before? So
like I said, ma'am, like I said in the beginning, before the talk started, I've given up on angle alpha. So while I was the one speaking about it on and on for so long, in practice now with the newer lenses, particularly the new trifocals, I just don't look at it. I don't bother.
So a question to Dr. Mahipal. If a person has a higher order aberration and is actually keen on a multifocal and a spectacle independence, how would you proceed in these patients? Dr. Mahipal is not there. Anybody else on the expert panel? Dr. Namrata?
Rohit is there. Rohit is there.
Oh, Dr. Rohit?
Ma'am, one of the major flaws of understanding of optics is that we put a value which is very arbitrary about what is high and what is low. And that decides many times about putting a premium lenses to a patient. And many times, a lot of patients are denied multifocal or a good premium lenses just because somebody found that the coma was 0.3 or 0.4 and somebody said the cutoff was 0.3. The lot of coma and all these things do not have an age-matched normative data. They're all based on a healthy people and on especially with presumably no dry eye also. So 99% of our population completely adapts irrespective of how much coma you have if your cornea is healthy and not keratoconic. So if your cornea is not keratoconic, optically speaking, I would not put any amount of effort in looking at how much coma or how much trefoil or how much other lower order, higher order aberrations, which may not bother that person at all because they have become commensals. I call it commensal aberration because just become commensals, which does not bother him in any way. So I want to bring in this platform to make it very clear that these values actually prevent many people from not putting these lenses, and many people are denied a chance to get it done. Samresh brought out very beautifully the angle alphas and kappa. We did a study where we looked at poor angle and alpha kappas, and these were the people happy ones. And we had the other group where they were perfect and they had a lot of other issues. So that means our brain neuroplasticity is wonderful. So if it's not a keratoconic eye, if it's not a post-LASIK eye, if it's not an irregular cornea eye, I think these values of 0.4 or 0.5, I think it just makes a good presentation, but optically I don't see is impactful at all. And I have not seen a single paper which actually picks up and says that this is a cutoff and this is what we need to be careful about. I asked Dr. Samresh and others to comment on this because I think the platform here, Namrata ma'am, if she's there, the platform here should bring this message very clearly that these values, I don't know from where it came and who gave those values, but it's just been drilled by every speaker and every time. And it is actually pushing us away from doing these surgeries.
No, I just wanted your thought. I do agree with all that you said. I just wanted your thought that would we still definitely give them multifocal, but would we look at extended range of depth of focus lenses or the eye hands maybe, or would we go for any conventional good multifocal with a large optic?
Any conventional multifocal with a large optic before it decides on how you choose your lenses. In a healthy eye, these may have a huge impact in the optics of the eye. Just want Samresh to comment on this quickly, if he can, what I just said.
I think that's a great point, sir. I had actually hidden those slides, but since Dr. Himanshu brought up angle alpha, I thought I should present. So I've looked at it many times now. And like I said, like sir has put up beautifully, any lens you put in the eye, especially for us Indians with small pupils, mesopic pupils don't go more than 4 millimeters. There is no role, I think, actively speaking. If you find an abnormality, maybe then in any case, multifocal is ruled out. But for majority eyes, this is not a deterrent to a multifocal surgery.
Yeah, I think it's more important to look at the topographic regularity, the ablation zone size, and those aspects, then break ahead on the higher order ablations. And before we go to the next speaker, because I think we're running short of time, is it that post-refractive surgery, Samresh, you could take it, would you try to use abrometry as a way to plan your IOL, the negative spherical ablation and the positive? Would you really look into that?
So madam, abrometry is a standard in my pre-op workup, but I don't rely on any data out of it. So I'm not going to put any number from an aberrometric data to calculate anything. I just look at the regularity and the corneal aberration profile. And if it's grossly skewed, like we were discussing, I would not advise an AT IOL to the patient. But from pure data perspective, I'll rely on the tomographers.
Yes. Thank you very much. I think that's an important information across. So we shall now go on to our next speaker, a very dynamic person, Dr. Arulmozhi Varman, who is the chairman and medical director of Uma Eye Clinic, Chennai, a greatly astute surgeon, a pioneer in phacoemulsification in our country, a driving force to keep all the latest technologies of cataract surgery at the forefront. And he is going to tell us about how to be precise in a refractive cataract surgery. On to you, Dr. Arulmozhi.
Thank you, Dr. Chitra. You can hear me?
Yes, yes.
Yes, fine. Thank you so much. So everybody wants to do a perfect cataract surgery, particularly when you have these advanced lenses where you don't want to go off and have the patient eat your head because he's paid you a large amount of money and he's not happy with the outcome. So it starts with biometry. I think that's been all covered. I'll just go through it for sake of completion. You do a good biometry, you do the right calculation, you choose the right IOL. Then that comes to that last little finishing touch, the surgical technique. So it's a combined effect that starts preoperatively and then goes on right up to the surgical steps and also eventually postoperative follow-up of the patient. So just no amount of emphasis can give the importance of good biometry where you need to do a perfect keratometry, get a good AC depth, white to white, lens thickness and axial length. All of these can be got off even from an ultrasound biometer if they're done properly. If you have access to a SSOCT based biometer, nothing like it. So the keratometry is the most important point. Most of us think it is axial length. I'm sorry to say, I think keratometry is the most important reading that gives you the maximum number of errors. You can do a good manual keratometer. Autokeratometer is fantastic. The newer telecentric is superb. Nothing beats it. A posterior K with a true K really puts the cherry on top of the cream, and then you get the perfect results. The topographer, yes, when would you use it? When you really want to know the axis on placement of the toric IOL, or when you want to really know the toricity to calculate the toric IOL a little better. In all situations which are abnormal, like post-LASIK, post-RK, a keratoconus or a highly irregular cornea, a topography is extremely important. We need to know not only just the axial length, we need to know the ACD, the lens thickness and white to white. All of these can be read off Manually, if you have an automated instrument that gives you all of these, well and good. Strepsod OCT would be the best, is the gold standard now. It doesn't mean that you throw out your ultrasound biometers. You can work with them too. White to white can be taken off with just a vernier caliper. Formula, today's formula, which is available off the shelf, would be the Barrett Universal 2 Toric. Put all your calculations on the Universal 2 Toric platform and then go by what it says. Don't believe just that there's a low astigmatism or low K value, you don't have much of a toricity. Go by putting this the calculations into the toric platform. And if the Barrett Universal 2 Toric tells you to put a toric lens, put it in. Of course, newer formulae such as Kane and Evo are on the offing. Let's wait for that. Of course, then you choose the right IOL. Whether you want to put in a toric IOL, a multifocal, a EDOF, an aspheric, or sometimes you choose to put in a spherical lens. When would you put a toric IOL? If your corneal toricity is more than 1 diopter, I strongly recommend putting in a toric IOL. Yes, can you do a LRI and get away with it? LRI works well in low astigmatisms, but in anything more than 1.5 or 2, I would strongly recommend a toric IOL. You put in a toric IOL, marking becomes very important. Manual markers are still very accurate. Yes, a markerless system is fantastic, takes out a lot of guesswork, but a properly done manual marking is as accurate as the most advanced markerless system. Then we come to the surgical pulse. First thing is that your incision has to be astigmatically neutral. Doing all your calculations and doing a bad incision that induces astigmatism or changes the astigmatism, the axis of astigmatism can be a catastrophe. The CCC should be central and properly sized so the lens stays inside the bag, does not pop out, does not tilt, does not rotate, will not go into a capsular bag contraction syndrome. And of course, you should align the IOL properly at the end of surgery. If the postgraduates who are want a single slide that takes the most important slide, this is it. To get a perfect phaco, you need perfect aseptic preparation. Povidone iodine over the lid and the lid margins. Povidone iodine in the conjunctiva, proper draping, isolation lid margins. You can do everything perfect and go wrong here and have a catastrophe. So please do not forget this simple step and then go to the more advanced ones. Incision should be as square as possible, ideally temporal, because temporal incisions do not cause any kind of an astigmatic induction. It has been proven by multiple studies that you can go up to 2.6 millimeters temporal incision that's placed posterior limbal and as square as possible will induce astigmatism as low as 0.12. So my advice is to go for a 2.2, 2.4 posterior limbal placed temporal, ideally square incision. How do you get as square as possible? Use a marker. This is a marker which gives you a mark on the cornea that's about 1.25 millimeters. So you make a groove at the limbus, posterior limbal, and tailor your incision perfectly 10 times out of 10. Dimple in there. So you get approximately a 1 millimeter length to 1.25 millimeter length, which is brilliant for astigmatically neutral. CCC should be again central, ideally sized. It should be about 5 to 5.5 millimeters. Well, we have access to a femtosecond laser, nothing like it. You can get the best incisions and best CCC, but how do we go about it? Again, use a marker. You can use a 5 mm marker, mark it centrally on the cornea. This mark is quite visible. And most important, use the right viscoelastic. It is worthwhile spending that little bit of money extra. Use a soft shell technique that will be very kind on your endothelial cells. So you can still see the mark that you made on the cornea, and that can be used as a template to make a perfectly centered and perfectly sized capsular axis. Of course, if you have access to a markerless system, nothing like it. So again, perfect phaco, you use an appropriate viscoelastic. It's extremely important. A soft shell technique goes a long way in giving you a good, quiet, and happy cornea. Ideally, a dispersive during phaco and cohesive during IOL implantation again goes a long way in giving you excellent outcomes postoperatively. In the back, phaco is very important to avoid endothelial decompensation. Where you cannot do complete in the back phaco, come out in the iris plane, avoid doing in the anterior chamber phaco as much as possible. So this is again using the marker. This is a different kind of a marker again. The complete surgery. Appropriately place side ports which don't leak is very important to give you a safe surgery. The right viscoelas taken and the marker that you can see on the cornea, or you can use a markerless system to make a perfectly centered rhexis. Decompress before you do hideout dissection. Do it in the right plane. You would find that you have hardly any cortex to remove at the end of surgery. You can choose any kind of a technique of phacoemulsification, whether you can do a straight chop as I do now, a stop and chop, a 4-quadrant technique. It hardly matters, whichever you're comfortable with. But again, remember the basic premise that do everything as much as possible in the bag. Don't come out outside the bag. Use appropriate energy settings. Do not stretch the wound. Don't make the wound floppy at the end of surgery, which can induce astigmatism. Most of this work is being done in the bag, and whatever last bit at the iris plane. A good IA, taking out all the visible cortex.
Sir, you have 1 minute remaining.
Yeah, thank you. Under the cohesive, and where you're using a toric lens, yes, if you have access to a markerless system, it's very good. But believe me, manual marking is as accurate as an advanced markerless system. So phaco is meticulous attention to biometry, formula, charts of IOL, meticulous surgical technique. Most important, don't not count on the asepsis. It's extremely important that you don't get into any catastrophes. Thank you.
Thank you very much, Dr. Arul. I mean, you covered every single point. This is a question. I don't have any question for you, but just one question which is there in my mind. I want my panelists to think and answer. I myself need the answer. What is the role of total keratometry in normal versus abnormal eyes, atypical eyes? Now, is it that it's because of the total keratometry we are doing better in the atypical eyes? Or is it that the IOL formulas are so planned and specific for these atypical eyes that our results are better?
Simple. The most advanced formulae require total keratometry to arrive at the most accurate IOL power, be it a normal cornea or abnormal cornea. The advantage of Barrett 2 toric calculator is that when you do not have access to a tomographer, you don't have a posterior K, it assumes it. It asks you as to which machine that you use. Is it manual or auto K? Asks you to give in 2 inputs from 2 different instruments and assumes the total, the posterior K, and arrives at an assumed total K, which works quite well. But where you have the ability to actually calculate the total K and the posterior K accurately using the appropriate instruments, it does put you into that sweet spot, whether the eye is a normal eye or an abnormal cornea. It does not make any difference. It makes it accurate across the board.
Yes, Namrata, you have anything to add, or shall I go on to the next speaker? I think that did sort of answer our question.
I think you can go to the next. I think there's nothing to talk after Dr. Arul's fantastic talk.
Fantastic talk.
Thank you.
Fantastic talk. See, 2 of us said the same words. So we shall now go on to our next speaker, Dr. Jeevan Tityal, one of the leaders of ophthalmology of our country. with many firsts to his name, very many awards and accolades, heading the RP Center with an extreme dynamism and terrific skill sets. And we are all going to watch how wonderfully things are going to evolve in his tenure. And we look forward to your talk, Dr. Titiyal, intraoperative OCT and its utility in cataract surgery.
Yeah, thank you, Chitra, for the invitation, and I appreciate ARC team putting so much effort in disseminating knowledge across the entire ophthalmic fraternity. I think we did have discussions on the various aspects of modernizing the cataract surgery to improve your outcomes. So this might talk, though I have spoken in many forums before also. This is like taking your clinical investigations onto your OR, especially the entry segment OCT. And if you have something better, which gives you so much detail on the table, nothing will be better than that. So this is what I think, potentially what all areas where we can have advantage of intraop OCT, which are attached to some of the microscopes to give you actual visibility. In a routine cataract surgery, which Arul talked about, looking into incisions, the hydro procedure, and intraocular lens positioning, there are three critical points where this will help us to judge how effective your surgery was on the table actually during your steps and subsequently after completion also. Then most importantly is the challenging cases where it has a great role in actually doing a on-table assessment, and also tells you what is the dynamicity of each step of your surgery on these difficult cases like wide cataracts, hard cataracts, posterior polar cataracts, subluxus cataracts. It does have its impact in improving your surgery. Then other part, which may not be cataract, but faking intraocular lenses, has a great role where we can assess the intraoperative bulk, which may be sometimes beyond your imagination to very shallow to very, very steep bulk, or sometimes the lens may be inverted, inverse. That can be real help. So we could publish the entire gamut of use of anti-segment OCT in anti-segment surgery also, right from the ocular surface surgery to the cataract surgery, cornea surgery as such. So just let me take you through various aspects. The first thing I would like to delineate is incision quality type, which Arul talked about, making it absolutely square shaped. Other important consideration would be what is the planarity of your incision. Uniplanar, biplanar, triplanar, which we talk about. And most importantly, the distortion which can happen during your surgical procedure of this incision, can it be checked up? That is also important. And the damage which can occur to your incision can also be seen. If you see here, this is a uniplanar incision, you can see very clearly. This is a triplanar incision in a manual blade incision. This is a femtosecond giving a very nice triplanar incision. And the impact of this incision we have seen with IOCT examination, where we found that manual incision versus femtosecond incision and the DMD associated near the wound site is very important to see. This is a post-op anti-segment OCT images also with that. And we realized that if you do a nice orientation of incision with femtosecond, the chances of a wound site DMD is less with the femtosecond incisions. The second important aspect would be to see what type of hydro procedure we have done in these cases, which normally we clinically talk about the upward shift of a lens diaphragm, a fluid wave, but it's very difficult to see if you have achieved the cortical cleaving hydrodissection. If you see here, very classically, we know that the posterior capsule is clean, there's a space, and the epicortical cushion is also detached from there. So this is the actual cortical cleaving hydrodissection which we have achieved here. This is, you can see, epicortical cushion. This is a space which we have created, and this will be decompressed as soon as you make a compression through your needle in these cases. So this is what I am talking about, incision, the distortion which can happen after completion of phaco or after insertion of IOL can be seen in three-dimensionally. People measure two-dimensionally with various devices, but the distortion three-dimensionally can be measured by IOCT attachment. This is the tilt and position lens can be judged with these. Other area we talked about the difficult case scenarios like a white cataracts, where we could classify the white cataracts on the table based on images which we could pick up. So these are various range of images which can be picked up, spectrum of white cataracts, which we deal with routinely in all difficult cases. So this is a type 1 where you have a regularly arranged lamellar cortical fibers and minimal intralenticular clefts. So this is a simple case where you can do a nice capsulorhexis without fearing the rhexis getting extended into periphery, like this case is a type 2 variety where you have multiple sheets of a cortical hydrated fibers and clefts which are intermingled between the hydrated sheets and very less fluid in these cases. So as soon as you make a neck, you have an the cortical sheet bulge out like a mountain, and this jeopardizes your rhexis going to periphery very, very soon in these cases if you don't make appropriate steps. If you see this video here, as you make a small nick here, you can see that there's no fluid will come out in these cases. The fluid is in between the fibers. The entire fiber raises the mountain and puts a pressure on the periphery. If you don't have a visco compression in periphery, difficult to make a small rhexis here, decompress the pressure from inside with bimanual aspiration. Needle decompression may not work in such cases. So you can see after decompression, entire bulge becomes convex and rhexis can be completed very, very effectively in these cases. Type 3 has a combination. You have a hydrated sheet and you have a multiple pockets, but you can see they have already broken the sheet. So these cases, needle aspiration might work, and you can also do a routine surgery in these cases without fearing any difficulties. And type 4 is routine, cases where going towards a hypermaturity. Entire thing is a fluid which is milky. And if you puncture, the milk comes out and your pressure goes down and surgery becomes very simple in these cases. I would say IOCT is a real help in improving your surgical technique. The change which can you do during your procedure of rhexis is very, very important. 2-stage versus single stage, needle aspiration versus bimanual aspiration, or a punch people talk about can be assessed by IOCT. Second aspect is a posterior polar cataract. Those can be assessed. So you can see here, this is a totally defective opening in the posterior capsule in a congenital case. These are other varieties where you have an intact posterior capsule. They can also be classified depending on the morphology of cataract. This is what you can assess the entire posterior capsule. This is type 1. Type 2, where you can't assess the pole, but periphery you can see the posterior capsule. So these cases still may have an intact posterior capsule. This is type 3, where entire range of a posterior capsule cannot be picked up by your OCT because there's a shadow, and this posterior polar disc is very, very thick. So you have high chances of posterior capsular rupture happening in these cases. So type 1, we do hydrodissection and hydrodelineation both for a safety. And type 2, type 3, where we don't do hydrodissection, we do just hydrodelineation. And that is decided by the picture you see on the table. You can see that the completion of surgery, intact posterior capsule in these cases. Type 2, type 3, we don't do dissection, only delineation. You can see multiple delineation we can do in these cases. And subsequently, you can complete the surgery. The IOCT will also tell you that if your posterior capsule is intact or not towards the end of your emulsification. Like you can see here, we have done a complete nucleus emulsification. This is epicortex. And the thickness of epicortex also tells you that PC is intact. You can see this is a PC intact in this patient. This is a sign which will describe the posterior polar cortical disc defect, which is very, very common in a posterior polar cataract. This is what picture video we sent to APACRS. We got a best cataract session film award this year. And also from AIOS, we got a best session award in this particular case. To summarize IOCT, as I told you, this takes your clinical investigation like anti-segmental OCT to operation theater, makes you feel better, make you see better, and make you perform the surgery better to have improved outcomes. So you can assess the various types of cataract, classify them to your surgical analysis wise. You can also look into a risk of PCR or a rhexis extension.
So 1 minute remaining.
Defect. The incision architect, which is so important to improve your surgery on the table, also decrease the complication happening in the post-op period is also very, very important analysis with IOCT, especially the descemal membrane detachment, which can occur in difficult cases like a Fuchs cases. If you don't see them, then the descemal detachment can enlarge and become a totally hazy cornea next day. So this is what we talked about. We have Atypical 800 for last 2 years. And this gives you a real good view of surgeries, especially OCT is so clearly visible now. You don't have to see the OCT through microscope, which is sometimes difficult. The screen gives you so much of big picture. It tells you everything in a great detail. And it's a great teaching tool for teaching institutions. In a COVID time also, all people can be sitting almost 2 meters away from your surgical field and have the same feeling what a surgeon does. So this has a future. And I am pretty sure future microscope will have attachment like this, where you have a heads-up surgery done in the 3D manner. Thank you, and I wish you all the best for the future, and see from a distance and better and bigger and more magnified, more clarity of your surgery. Thank you, Chitra, for invitation. You are muted, Chitra.
How this would coexist with the 3D visualizing systems. So you've answered that. But for a general ophthalmologist, how wrong are you if you just rely on the AIOS for assessing the PC integrity, excepting for the fact that the AIOS you can get some false negatives and that IOCT is real time. But in majority of the situations, I think you are okay with
you're absolutely correct, Chitra. You can clearly assess these cataracts on anti-segment OCT, and the same picture is seen in the IOCT also. So this is now we talked about posterior segment OCT. We talked about topographies. Anti-segment OCT is also a significant tool, has to be there with a cataract workup now. Especially for cases with posterior polar white cataracts, it is important. Cases where you've done a vitrectomy, other things, it is really important tool for all of us, and it should be there. The only thing which may not give anti-segment OCT is what happens once you make a particular step. I make a nick on the anterior capsule. I can't assess that in the anti-segment OCT. It gives you just that, okay, this might happen. But what happens on the table, that is picked up by IOCT.
Do you think the future, with so much information about the capsular bag dimension and all which is available with IOCT, it will bring in a greater nuance in IOL power calculations in future?
Definitely. I'm already on into this work, because after we implant the IOL, we remove the viscoelastic. And once we start hydrating the main wound and side port, you can see the distension of a capsular bag and the little movement of lens, especially if the lens is not fitting into a capsular bag. Especially if I use a Technist lens, the lens moves from this capsular bag. And we are just titrating the various types of cases, and we'll correlate with the measurement of IOL Master 700, which is the lens thickness, the volume. So we are trying to correlate with the capsular bag position is going to similar. So we are having IOCT videos and trying to assess them, correlate with the pre-op assessment, and try to come out with some algorithm.
Thank you very much, Dr. Tityal. Always, it's a treat to hear you. So we shall go on to our last speaker, another amazing surgeon, Dr. Anurag Mishra, who's a consultant pediatric squint and oculoplasty of Kar Vision Eye Hospital. I want to know what he is doing with the cataract still. So another great surgeon who is very techno-savvy, and you can see it in this photograph itself. So we really need to know all that you're going to tell us about advances in IOL technology. On to you.
Thank you so much, ma'am. Good evening, ladies and gentlemen. Gratitude, ARC, Chitra ma'am in particular, not only for the platform, but also for the topic, because it propelled me to take serious deep dives into some very interesting concepts. So hang on if you thought that the IOL technology has reached its summit and perfection, because there's still a lot more coming up. And here's my list of recent advances in IOL technology. We'll start with one concept which has already received the US FDA approval. It's called light adjusted lens. And the light adjusts this lens after it's implanted in the patient's eye. This concept was introduced by Daniel Schwartz and Robert Grubbs, and it got an approval in 2017. The material of this IOL it's built built up of macromers, which are photosensitive molecules essentially, and it's embedded in a uniformly silicon matrix. So the material is silicon. That's what we are going to start with. The concept with which this IOL works is these are the macromers which are there, the pink shaded things. After IOL's implantation and you do a diffraction and find a refractive surprise, the IOL gets exposed to light, UV light, of a wavelength of 365 nanometers. What it does is it propels the macromers to join ends and produce polymerized macromers. This creates a concentration gradient inside the substance of the IOL, and the unexposed macromers travel to that area, increasing the curvature and thereby altering the dioptric power of the lens. After that, a second bout of exposure to the same UV light is performed to lock in the effect so that no further change can be produced. So it's a very interesting concept indeed, but there are a few buts. So this is how a myopia is corrected. If you have a residual myopia after implant, the light is projected onto the peripheral parts of the iris, peripheral parts of the lens by a light delivering device or an LDD, which is kept at the OPD. So the IOL assumes essentially a dumbbell shape. It becomes a biconcave shaped IOL. And then there's a lock-in to adjust the myopia that the patient was residuing with. In contrast to that, if a hypermetropia is residual, then the central part of the lens is exposed to produce the same effect. It increases in its curvature and convexity to adjust the dioptric power and give you a proper optimal correction. There are a lot of flip sides. To start with, it is a material which is made up of silicon. We all know what comes with a silicon material, what all comes with a silicon material. It's a biconvex, it's spherical in its design. The aspheric design has not been come out. It's a three-piece or a multi-piece design. It's not single-piece design. It's something they have not come out with as yet. The pupillary dilatation of the patient has always to be on the other side of 7 millimeters. A smaller pupil, you just cannot do the procedure because if it's a myopic residual, we just saw that the peripheral parts of the lens have to be exposed to the UV light. After all this juggling, what they found is 92% of the patients with a 0.5 dioptrosphere and 82% within 0.5 cylinders. Well, you ask yourself, without all this juggling, perhaps my patient population also fits into this sphere. So why this? Protection against UV light in nature. UV light exists in nature. So the patient wanders around after the IOL implant. The naturally existing UV light can also alter the IOL into an extent. So till the time that the patient is exposed to this particular UV lamp in the OPD, the patient is given a pair of UV protective glasses actually to prevent any damages or prevent any changes occurring to the IOL. And it is an expensive proposition as well. The second concept that we are talking about is bag in the lens. This was introduced to the world by Mary-Jo Stazington. The material is hydrophilic acrylic with 28% water content. Well, you again say that this is perhaps not good enough in the present technology. It's a biconvex disc. It does not have haptics. It's just a disc having a circumferential groove. And the technique is you do an anterior axis, you do a posterior axis, and then implant this disc and feed the anterior and the posterior capsular margins together into the circumferential groove that is there in the IOL. The capsulotomies have to be matching in size and centration. However, they may not be congruous, in which case only one part of the capsular axis margin can be fed. To ensure a match into the circumferential groove, the innovator has also designed a caliper, a ring caliper which comes in, and we can use that to mark both the anterior and the posterior capsules. High molecular viscoelastic, high molecular weight viscoelastics has to be pushed into the Berger space before you perform the posterior capsular axis. And after you put in the IOL, all that viscoelastic has to be washed from behind the IOL, which might be a little difficult because both the disc and the axis and the capsules anterior posterior combined would be flopping in there. If you have if you have a desire to have a perfect match, you can also combine with flax, but with flax you have to do the PCCC and the ACCC both with the flax machine, so that consumes 2 of your PIs, just escalating the cost for the patient, you know. And if you have a capsulotomy break or a zonular dehiscence, they've also come out with these segments, which they call the bean segments. They are also to be fed into the circumferential groove on one side, and the other side rests in the sulcus to give them a proper fit. This IOL is also available in the toric versions. And the only practical advantage with this particular design is that it does not lead to any PCO. They have also come out with something very interesting. They say that if you implant a bag in the lens IOL, then there is a minimal myopic shift in pediatric eyes. Why? Because the lens epithelial cells remain in their natural position, and that is how they keep the bag flexible and stretchable. So consequent to the stretch in the eyes with advancing age, it perhaps does not lead the patient into too much of a myopic shift. But there are a lot of flip sides of this. They haven't mentioned anything regarding ELP and how a constant modification should be done in the power calculation part. Technically, it is a difficult procedure and an expensive procedure as well. And finally, future posterior segment surgeries might just be difficult because you have a long opacified area in the periphery, all thanks to the opacification in the capsule, which is bound to happen with time. The third concept is drug-eluting IOL, which essentially is a drug delivery system of IOL when it's put into the bag, and the concept actually augments dropless cataract surgery. We have gone into needleless, we have gone into sutureless, we have gone into bladeless. Now it's time that we look at dropless cataract surgery. There are three ways in which drugs can be added onto the IOL. Either you coat the surface, in which case the whole surface of the IOL is coated, barring the sides. Soak the IOL in an active molecule, in which case the sites also get impregnated with a solution. And the final drug delivering technique is loading the IOL haptics with slow release devices, which release the drug after they're implanted. These are the drugs tried: dexamethasone, ciprodexa combination, moxodexa combination, and this doxorubicin incorporated chitosan, which essentially prevents the future posterior capsular opacification. So all of them have been tried, but they have been tried in models and animal models as well. The advantage, as we discussed, is just it ensures a dropless cataract surgery, perhaps sometimes in the future, but there are a few flip sides as well. The first of foremost of which is this hydrophilic material again, because otherwise you perhaps cannot make the drug soak into the substance if it's not a hydrophilic material and is not permissive to the solution that you dip it in. It affects the optical quality. They've seen that it initially does affect the optical quality till the drug is delivered fully, and then the optical quality improves. So for that time period, the patient would have to manage with a compromised quality of vision, which perhaps would not be acceptable. Intracameral concentration after the initial delivery is not predictable. So we need the intracameral solution of the drops to be continued for a period of time after surgery. We're not sure that whether that period would be covered with the one load of drugs that are incorporated into the IOL substance. The next slide would begin with some amount of glamour, actually, because this features an outrageously good-looking man who is also the innovator of a swivel haptic IOL, a very interesting concept. Again, I'm thankful to Dr. Sri Ganesh and Dr. Sheetal for allowing me to include this in my talk and also share with me the material. This is an open-loop single-piece hydrophilic design, but it has a set of extra haptics at 3 and 9 o'clock positions, which stay folded when you load them onto the cartridge. But once it opens in the bag, you just have to swivel them and they suspend the rest of the IOL from the anterior capsule. The advantage is
Sir, you have 1 minute remaining.
Is it has more predictable ELP. It has no decentration or tilt, and it negates the negative dysphotopsia as it stays very close to the posterior surface of the iris. But the flip sides are, well, it is a hydrophilic material. Again, there is the contact with posterior capsule is presumably going to be less. Estimated A constant they have told is 117.5, but their article also suggests that they had seen a change in the spherical equivalence from plus 1.75 diopter to minus 0.75 D in a period of 6 months. I would have loved to have Dr. Sri Ganesh's opinion on this. The final concept that we are talking about is EDOF without multifocality. So diffraction-free EDOF, a very interesting concept that has come nowadays. Before understanding how it works, we have to see how the depth of field works for us. So this is the visual field where the near, the intermediate, and the distance objects are placed. With a monofocal lens, we have just one point focus. And when you have a near object being looked at, the focus changes to behind retina, and you have a blur circle coming into focus on the retina. So you cannot see things properly when objects are located in a nearby distance. What the EDOF does is it stretches the point focus into a line focus, and it also shifts it so that when you have the distant object, the rear end of the focus comes into this focus on retina, and you have a near object in the proximal end of the focal line comes into the focus in the retina. And how it does it is by extending the central part of the wavefront into a line. So that's how it does it. And I will just look at this small animation. So this is a normal wavefront, and this is the extended wavefront. How it does is in the IOL is that there is a small modification at the center by means of a smooth plateau and a curvature change right at the center of the IOL, expanding 2.2 millimeters. So it converts the focus into a line, all right, and it also shifts the focal line into a little anteriorly. So it expands the wavefront and it also expands the focus and it brings it front. Advantages: there is no light distribution in this technology of 87 and 13 for distance and near. So there's presumably no effect on contrast sensitivity. I just wanted to add a point to Dr. Samarish's talk in this, apart from doing the other things on eye trace, a part of my routine workup, particularly when I'm planning an ATIOL and in particular when I'm planning a multifocal or trifocal, is to see the modulation transfer function curve on eye trace and to look at my patients where they fall. If they do not fall well within the square that the machine gives me, I'm very careful because their contrast sensitivity is already compromised and the multifocal is going to compromise it further. I do agree that angle alpha does not play a major role, but what plays a major role, in my opinion, before you plan this is looking at the modulation transfer function curve. So there are a few flip sides. You cannot have a perfect EDOF according to principles of physics. There is a curvature change, so you might have compromised quality of vision. Before we wrap up, there's just a few honorable mentions. This is my last slide, so hang on just for a few more seconds. There's a concept called open bag IOL. And this comes from a thought that we have seen that if there is a free passage of aqueous into the capsular bag, it leads to less of PCO formation later. So what this open bag IOL does is, it has a 2 layers of complete circles of haptics bridged by pillars, vertical pillars in between, which act as conduits for the fenestrations. They act as conduits and they allow a free passage of aqueous into the bag. Fluid-filled IOLs and modular IOLs are essentially accommodative IOLs. They have haptics which are silicon gel filled, and they're accommodative. So the flow of silicon oil gives some amount of pseudophakic accommodation. A variant of light adjusted lens, the LAL, is femtolaser induced alteration in IOL power. We call that FEMTIS, or the innovators call that FEMTIS. It is better than UV light exposure, at least because you don't have femtolaser light in that wavelength occurring in natural light. So you don't have to be very protective to the patients. You can always do that later on, exposing to the effects of femtolaser, bringing about the same change. Sorry for overshooting the time, ladies and gentlemen. Thank you so much, Dr. Chitra, again for the opportunity and the topic. I sign off now.
Yeah, wonderful talk, Anurag. You really opened up the whole world of recent technologies. I have a question to you. When you are choosing a new multifocal based on the different benchmark studies, would you want to look at the defocus curve, the modulation transfer function, or the point spread? Which of the three would you prioritize on?
All three of them, ma'am. It's very difficult to prioritize, actually, because all three of them play a very important role. The defocus curve definitely is important because we have to know the patient's lifestyle and the concentration and the cord length of the lane length of the patient. So that has to be identified with precision. And the modulation transfer function curve, as I said, it always forms the routine part of my cataract evaluation, particularly when I'm planning an ATIOL. So point spread function again is important, but point spread function is perhaps not that important if you are taking into the lower order aberration correction precisely. If you're correcting the lower order aberration very perfectly, then the point spread function is going to have a confluence of very acutely compact spots. So that perhaps will take the third spot, but these two are equally important to me.
So I have question which even Anaga or Satyajit could also answer, or you could answer. What would be the percentage of this enhanced monofocal in your practice? Would you use it just as an alternative for a 3-piece IOL and with some depth of focus, or you believe some more in it?
At the moment, there are only two concepts lying with us. The one is called the eye-hands and the other is DVT. Now, there is a massive difference in the price factor of these two IOLs. While I've used both, I must say this, that the iHands is, to me, it's just a monofocal IOL. It does give a little bit extra in a few cases after bilateral implantation, and in particular, if you are leaving the patient behind with a small amount of myopia for distance. The VVT performs better. It is better in its performance, but it is very highly priced. So at the moment, VVT occupies that small segment of patient population in my practice, wherein the patient's interested to have an added intermediate vision in particular and a workable near vision, but is unsuitable for trifocals otherwise. The patient's a frequent night driver, or even otherwise the patient's unsuitable for trifocals. That small segment of patients is where I choose the VVT for.
Thank you. Anganaga, you have anything to add? I think he said it all, no? Anaga, signal's not there.
Ma'am, there have been issues of glare and halos with iHands. What is Dr. Anurag's take on that?
As I said, Dr. Satyajit, I mean, even without halos, it does not somehow, apologies for saying this on a platform like this, but it does not really make me happy post-implantation feedback from the patient. So not a very avid user of that. Sorry.
Okay. So I think all of us get back to our dinner, and I think I shall make my concluding remarks. Satyajit, you want to say anything?
No, ma'am. No, ma'am. I'm done.
So I think we today definitely stand stronger with a very refreshed understanding of all the relevant technologies which we need to embrace in cataract surgery. And on behalf of ARC, a very heartfelt thanks to our dynamic set of speakers who truly added great value to the webinar with their thought processes. And of course, our great expert panel who ensured that all the pearls were brought out at the relevant moment. My deep felt thanks to all my wonderful co-moderators, Anagha, Satyajit, and Srinivas Joshi. And of course, the great team that we are together. My thanks are due to the AIOS admin led by Mr. Kripal, Sai, Manjula from Numerotech for the solidarity of support, and the highly charged office staff of mine, Mr. Vel Murugan. My thanks to the webinar admin led by Anand Sethi, who really look into all that has to be seen. And my gratitude and solidarity to solidarity to Sun Pharma. I'm so sorry. This is a PG update, and the PG update is so close to heart of Sun Pharma for sponsoring our PG update events in the recent past. And finally, our immense thanks to attendees for their gratifying presence and that encouragement which they give us to try to come back to each of you with newer and newer programs. Stay tuned with us. Stay tuned with ARC. Thank you very much, one and all of you. Thank you.
Thank you, ma'am.
Thank you.
Thank you so much.